All right. Hello. How's everyone doing? Good. It's good to have you guys here. It's good to be live and in person. I know it's been weird, with COVID and Zoom calls, and it's almost, sort of surreal to be here finally in person. But so welcome, and we're really excited about our new center here in Avon. I'm sure you've had patients that have come through here, and it's been a great sort of addition for us. We've for so long we had our center in Brecksville, and obviously we were biased. We're like, oh, Brecksville's great, but now that I see, on the west side, that is a far drive, and more and more every time I bring it up, and patients are like, oh, I have cataracts. Well, where can I have it done? I say Avon. I just see this sort of relief in their mind. I think they've heard about us and heard about what we're doing in Brecksville and wanted to have us as surgeons, but that drive definitely adds up. And so to have the ability to offer the same style of care that we were doing in Brecksville here in Avon, and quite frankly, I don't know if we have any Brecksville employees here, but quite frankly, I think we've stepped it up as far as the facilities. It's 10 years newer, and it's been a great addition. So to have this on the west side to service all you all and our patients, our mutual patients, it's been a great joy. And Shamak, if you want to say a couple.
No, the other thing I would say is that besides cataract surgery, I think the other nice part at this facility is that we've got a plethora of other subspecialties where we can go and do procedures. You all are aware of Daniel Pierre, who'll be talking later on here, but he does a lot of his strabismus work over here. We just recently had Dr. Davis join us. She's an oculoplastics doctor, and she'll be actually talking later on today, but she also does oculoplastics right over here. Also, Dr. Cosmides, who's a glaucoma specialist, he'll be starting to do procedures here starting January 1st. So basically, we've almost got the whole gamut from that perspective. So from a west side perspective, like Bill was saying, we have the ability to go ahead and not only just see our patients here, but basically do all our procedures as well.
Yeah, thanks, Shamak. And we do have Retina Associates does come here as well. They obviously, there's a number of different great retina practices in the area, but we've always had a great relationship with them, and they have practices in the region. But it's also nice, if you ever need a patient to be seen, and you like our team, we're also happy to sort of work with you all with Retina here in this building. So we'll go ahead and kick the talk off. We're going to talk about enhanced monofocals and extended depth of focus. As you've probably seen with with contact lens industry or glasses, there's always things are pushing the limits and things are always getting better. And IOLs have been a lot of the same technology more or less over the past 20 years, but it seems like in the past year and a half, we've seen an explosion of IOL options that we're offering to our patients. The newest category that's become popular is this enhanced extended depth of focus lenses. These are our disclosures, and just wanted to start with a consideration. Let's say a 60-year-old history of cataracts that's presbyopic. What are you all thinking? Like, what's your go-to recommendation for this patient? I know it's a minimal history. Just assume it's 2+ cataracts, otherwise normal eye. What are you all thinking? Anybody multifocal? Hands up for multifocal. Chuck? Multifocal, good. Do you just say, go distance both eyes, and you're just going to wear reading glasses? Anybody just sort of do that? A little bit of that. Monovision. A lot of monovision. People like that. It's interesting. There's a few different options, but we'll kind of keep that in mind as we go through some of the slides. But extended depth of focus, we'll go through an overview, where to use them, advantages and disadvantages, and some considerations. As you all have known, monofocal lenses give really pristine, high-quality distance vision. All the light is focused on the retina, but you really have very limited near vision. You've probably seen patients that have complained. They say, Doc, I'm seeing great distance, but I can't see the food on my plate. I'm having trouble, being able to do anything near, put makeup on or whatever it might be. And so monofocals are great for distance, but you do have that limitation. Multifocal lenses, also great vision. You can see this depth of focus curve, but as you see, there's this side effect of sometimes glare, sometimes halos at night, and you have this sort of good vision, but there's a catch to it.
Right. And I think that's one key pearl that I want to talk about is that in general, with any type of IOL we may be talking about, there's always trade-offs. Like Bill talked about with the monofocal, there's a trade-off that you don't get any near vision. With the multifocal, you get more range of vision, but the trade-off is you may have glare and halos. And really, whenever we have a discussion with our patients, it really comes down to what is the trade-off that the patient is most willing to accept. And if you can determine what that is, that can help guide you in terms of which direction one may want to go on. Because at this point in time, we continue to work towards development of the perfect lens, but we're not there yet. And so as we keep working, we're going to go over to some of the lenses that have come out here and go from there.
Sure. Yeah, I agree, Shamik. So what we've seen is this extended depth of focus lens category more or less is designed to bridge that gap from multifocal and monovision. So it's sort of trying to give some extended depth of focus, but without those side effects that sometimes we see with a multifocal lens. So, basically increasing the depth of focus, but minimizing the side effects. There's a number of different categories that these extended depth of focus fall into. You have spherical aberration, diffractive optics, a zonal optic, or aperture optic, and we'll kind of go through each category on where those lenses fit. So case presentation, same patient, but now the patient's worn monovision contacts. Let's say they've worn that for the past 10 years. What are you all thinking? Have the patients come in wearing monovision?
Do we replicate that, or do we try multifocal? I mean, I'm just curious for
Eric,
thoughts.
what you?
I go straight monovision. If they're happy with it, I stick with it.
Yeah, good call. Shamik, do you ever change gears to multifocal on these?
No, I mean, typically if someone has been successful with monovision in the past, then we tend to gear more towards monovision. Although one thing that I want to emphasize is that pseudophakic monovision is actually very different than phakic monovision. What I mean by that is, with phakic monovision, patients in general have some degree of accommodation that they have. So when you talk about doing near and far, they still have some range of vision with that phakic monovision. However, when you go with the pseudophakic monofocal and you do monovision, you get distance, you get near, but what you have to let patients know is that you have to kind of trombone your hand to that sweet spot where things are going to be up close. And that may be where the patient wants it, or maybe a little closer, a little farther, but there is some variability inside there. So that's one place where you can use monovision with the monofocal, but what may actually work a little bit better is doing monovision with an EDOF type lens, because now you actually it replicates phakic monovision in a better fashion because of that range.
Yeah, that's a great point, Shamik. One other thing I'm going to just sidebar real quick. We want to make sure everybody's comfortable in the room. We do have N95 masks. If anybody wants, has some anxiety about mask or no mask, I know it's kind of a confusing topic when we're eating and you take the mask off and we're all in a closed room. I think a lot of us are vaccinated, but if anybody wants an extra layer of protection, feel free. There's N95 masks, but it's sort of mask optional. If you want to wear a mask, great. If you want to wear N95, great. But we could probably have a whole debate on the mask subject, so we'll stick to IOLs, but we want to make sure everybody is comfortable, and so we do have the N95 if anybody wants an extra layer of protection. So anyway, I think most of us would stick to monovision. I've been burned in the past. Patients come in, they're like, oh, I want to get that new multifocal lens, but you've been wearing monovision for years. Like, yeah, but this looks cooler, and then you try the multifocal. It's permanent. They're not so happy, and then they kick themselves like, well, I always liked monovision. Why didn't I just go with that? So those are sort of considerations. So the first category of extended depth of focus that we'll talk about is spherical aberration, and more or less, you see this slide that was quite common with laser correction, laser vision correction, looking at the higher order aberrations, the Zernike polynomials. If you look at that third line, that's the one that is kind of most common. You have cylinder on the sides and then sphere in the center. And if you go further down, let's say the next line, the fourth line, is what we call coma. And I like to describe coma as almost like astigmatism. It has an axis. So you can have coma kind of blurs the vision similar to astigmatism. It has an axis to it. It can be vertical coma, horizontal coma, or oblique coma. And so that's kind of almost like an echo of astigmatism. And if you go to the fifth line, you look at the center, that bullseye looking target, it looks very similar to defocus or sphere and cylinder, which is on the third line. And so basically, spherical aberration is sort of like an echo of sphere, where spherical aberration has a negative and a positive. There's not a directional component to it, but there's a negative and a positive to it. So more or less you can focus the light in front of the retina with spherical aberration or behind the retina with spherical aberration. It works very similar to sphere. So kind of keep that concept in mind. When you have a sphere lens, obviously we know that you can change a +1 or +2. You push the light in front or behind the eye. Spherical aberration kind of does the same thing as sphere, but a little bit different way, but that's just a good way to look at it. This is sort of looking at spherical aberration, and what it does is takes focused light and extends that depth of focus and sort of spreads that conoid sternum kind of out a little bit to extend that depth of focus. So you look at the top right, that defocus curve, and what that shows is as you add minus lenses to a normal lens, you more or less blur the vision and you have really narrow depth of focus. But you see the blue line there, it's called sort of an extended depth of focus. As you're adding minus lenses to the system, the patient has the ability to kind of still focus through that. And what that means is when they go to hold a near target, they still have that ability to see that clearly by stretching that narrow focus from a monofocal, stretching that out a little bit through spherical aberration. One thing to keep in mind, though, when you think about spherical aberration, there's lenses that can change that spherical aberration, but there's also the cornea. So there's two surfaces within the eye that can adjust the spherical aberration. You have to look at it sort of in total. So you have to look at the cornea portion and the lens portion. And those two things give you the total eye spherical aberration. Shamik, if you want to talk about this, you've probably seen these eyes with after LASIK eye
Right.
surgery.
So basically, a cornea that is a sort of a virgin cornea typically has a little bit of positive spherical aberration. But we all know that when we perform LASIK, or more specifically myopic LASIK, we tend to go ahead and increase that amount of spherical aberration inside there. So because of that, we're causing a greater amount of spherical aberration in that situation. However, when we go ahead and do hyperopic LASIK, that's just the opposite. We've basically gone ahead and decreased the amount of spherical aberration in the cornea. So why that's important is that when you have a patient, and these days when we do cataract surgery, I would say every surgery day there's probably at least 2 or 3 patients that have previous refractive surgery. You want to go ahead and look at the type of refractive surgery the patients had to determine from an optimization standpoint what type of lens may potentially work best for that type of individual.
Yeah, so it's not necessarily one lens fits all. You might think, oh, I've got this great lens. It has some spherical aberration. I'm just going to use it on everybody. The problem is if you use it on everybody, you may be adding to the system or you may be negating some of the spherical aberration. So you have to understand how it's being used. And so all of our patients, when having cataract surgery, we look at topography. And if their goal is to sort of have that extended depth of focus, we're keeping that in mind to achieve their goal.
And in general, just because when we do LASIK, the majority of patients tend to be myopic. There are some that are hyperopic, but if you look at 100 patients, I would say probably about 80 to 85 of them tend to be more myopic treatments as opposed to hyperopic. Because that's why you're going to see more of a spherical aberration of a certain profile as opposed to the other profile. But you still have to keep that in account. If you look at this, you'll see that there's a whole plethora of different lenses that are out there. And there's a whole range as far as the type of lenses that one may have. You can start on one side, which is the Rayner EMV. And again, some of these lenses have just come out recently. The Rayner EMV is one, and the Technis Eyehance is another one. And they're sort of on two opposite ends of the spectrum. Rayner, per se, typically has more, what I would say, positive spherical aberration component to it, whereas Technis Eyehance has more of a negative spherical aberration inside there. And if you want to basically go neutral, the B&L Invista is sort of like where it doesn't have any components. So if you're not sure exactly, do I want to increase or decrease, it may be somewhere in the middle inside there.
Yeah, great point. So in looking at the corneas, we're trying to match the proper lens to the cornea depending on the patient's goal. And so you may have these patients that say, doc, I had LASIK eye surgery, and ever since LASIK, I've noticed I haven't needed reading glasses, and they might be, let's say, 50 years old, and you'd expect them to need reading glasses at that point. And they might have some natural spherical aberration that was induced where they have some depth of focus, and so maybe you want to maintain that. You don't want to neutralize it. On the same regard, you might have a LASIK patient say, doc, ever since I had LASIK, the vision's not quite as good. It seems like driving at night, I have a little glare. the optics aren't quite as good. We often see this a little bit more with hyperopic LASIK. It has that steep central cornea, and they're like, Doc, ever since I had LASIK, I haven't need reading glasses so much, but the quality of vision is not quite as good. So then we've got to decide what our goal is. Do we want to sort of neutralize some of the aberration that was already put into the cornea from the LASIK, or do we want to kind of maintain that and not take it away? So we look at that. We can choose different lens profiles to sort of match that cornea to achieve that patient's goal. So, the Tecnis Eyehance, we both had a lot of experience in this. I'm going to let Shamik kind of run with the next few slides, kind of talking about how it uses, its platform to kind of extend that depth of focus.
Yeah, and before I forget, I do want to thank J&J and Raynor for going ahead and sponsoring the CE event. So thank you very much for helping us with this right over here. So as far as Tecnis Eyehance is a lens that got approved by the FDA just within the past year. And basically, it's a refractive lens that's based on the Tecnis one-piece IOL platform. It essentially is based on refractive technology where it doesn't have any rings. It's based on a continuous higher-order aspheric surface. Basically, if you look at both lenses, standard monofocal with the Tecnis, it's visually indistinguishable between the two. So how does it work? Basically, there's a proprietary aspheric optic that creates a continuous power profile to enhance intermediate vision. So what happens is there's this very gentle curvature in the central part of the lens. You really can't see it, but because of that, it basically helps to extend the overall depth of field. What's important is that it is able to maintain great distance vision without increasing the amount of dysphotopsias a patient may have. So that's always something that's critical, is we've talked about trade-offs, and what's nice about this is that we have the enhanced depth of field, but at the same time we don't have the trade-off of increased dysphotopsias overall. So with this lens, we're able to deliver intermediate vision with the monofocal IOL, and in this study they basically looked at what was different between a traditional monofocal lens versus the Eyehance, and basically it was statistically significant. There was a greater than one-line improvement in intermediate vision with the Eyehance compared to a monofocal. And that was monocularly. But again, with this, we're comparing distance vision. Again, it may look like there's a difference, but statistically speaking, there was no significant difference in distance vision between the Eyehance versus a standard monofocal. So we were able to achieve that very well. Looking at the dysphotopsia profile, if you look at the picture over on the left-hand side, you see that there's really not much difference between a standard monofocal versus the Eyehance. So as expected, they basically do not increase the amount of dysphotopsias as present inside here. What's nice is basically with this IOL, you basically have a larger sweet spot. And so where I found it extremely useful is if patients have previously had myopic LASIK. As we know, whenever you've had refractive surgery, ocular biometry sometimes can become more challenging, where it's harder to hit the mark and be exactly where you want it to be. Because we have this larger sweet spot that's being present over there, even if you're off a little bit on a biometric standpoint, you can go ahead and still achieve great overall outcomes in terms of 20/20 vision. So that's one place where I found that with someone who's previously had myopic LASIK, this works extremely well. So basically, Tecnis Eyehance is one of the latest innovations in the monofocal category, where we basically have improved intermediate vision, 20/20 distance vision, and a similar dysphotopsia profile as other monofocals. I'm going to have Bill now talk about the Raynor lens.
And so, if you saw that first sort of chart, you had Tecnis Eyehance on one far end with the negative spherical aberration, and the Raynor's kind of at the other end with positive spherical aberration. So two different technologies, both kind of achieving the same goal, but kind of working at different angles. The Raynor EMV, it's a one-piece lens, very similar to the other lenses that we use. Again, it has that aspheric center that designed to give positive spherical aberration. We were one of the first implanters in the U.S. Actually, I think our center was the first in the U.S. to implant the lens, and some of our other friends around the country were also within that first week. When looking at a new lens, you want to have a high-quality optic, a high-quality platform that's very stable. What's nice is the Raynor lens, you can see it has this double haptic configuration that gives it some stability inside the bag. One of the things with all the lenses that has spherical aberration, they are sort of sensitive to being centered within the eye. If it starts to decenter at all, you can imagine the optics don't work quite as well. You probably see that a little bit with, let's say, a contact lens where maybe an advanced contact lens where it's designed to give multifocality or it has spherical aberration built into it. But if the contact lens moves off to the side, you're not going to get the same quality of vision as if it were to stay centered. So the double haptic configuration gives it some stability within inside the eye. The studies are very favorable. That positive spherical aberration works quite well. There's some studies that show that a lot of patients may prefer positive spherical aberration over negative to give that extended depth of focus. It's comparable. The defocus curves are very similar to what we see with the eye-enhanced lens. These are sort of head-to-head defocus curves. You've seen it. We've been using the Rayner platform for the past 3 or 4 years. So a lot of our patients that have cataract surgery, traditionally, let's say that's basic cataract surgery, a lot of them have been getting the Rayner lens, and we've definitely fallen in love with just the platform itself. It's very easy to implant. You probably see it looks crystal clear inside the eye. You don't see glistenings or fogginess over time. The YAG rate is reasonable. It's not too high. Some patients do need YAGs, but it's easy to YAG. It doesn't have dings in it when we do the YAGs, lasers afterwards. So great platform. You probably, before we started using it, you might have been like, well, who's Rayner? I've never heard of that company. You've obviously heard of J&J and Alcon, Bausch & Lomb, Zeiss, Hoya. A lot of lenses, are big optical names, and Rayner is a little bit of a sort of, you might be like, well, where did this come out of? It was actually the company that built the first IOL in Europe, so it's very common in Europe. It's probably one of the most popular lenses in Europe, and it's relatively new to the U.S. So a lot of times we see that new lens platforms are coming out. For example, Zeiss just launched their new lens, and we're use that this week within the center. And obviously Zeiss is a big name in optics, but new to the U.S. for IOL. So every year there's going to be new lenses that come to market. This is one that's been popular in the U.S., and now they're kind of building on this platform with this extended depth of focus. So we've used the lens for some time, but just this is a new configuration. Very comparable to the other lenses as far as its qualities. This is just a quick video showing what it looks like being implanted. It comes in a preloaded sort of a system, so it's easy from a surgeon standpoint. You can see it. It's very controlled, comes out very soft, gentle within inside the eye. You see that double haptic configuration allowing it to center well within the eye. As you see in your post-ops, it looks crystal clear, very well tolerated, very biocompatible. So it's a great overall platform. This slide I think is great, and this is applies to the Rayner lens, but it applies to more or less all the extended depth of focus lenses. Shamik touched on it. With the monovision, how many times have you seen, let's say, a cataract patient that's had monovision, and let's say we were trying to target -1.5, and we hit that target, and you might have 2 patients in one day, and they say, Doc, this is too near. I have to hold it too close. And the next patient's like, Doc, I can't see anything. I have to hold it too far. A lot of it depends on where they hold things, where their natural reading is. And so it's hard to know what the target's going to be. When they're phakic, they have some residual accommodation. So let's say that monovision patient with LASIK, their natural lens can kind of fill in the gaps. With a pseudophakic lens, it's rigid and it's hard to fill in the gaps. So what's nice is the extended depth of focus kind of bridges. The distant side gets a little bit of intermediate. The near eye gets a little bit more near, and so we can sort of more precisely, hit that patient satisfaction where we're going to kind of fill those gaps in. And it's been frustrating trying to kind of, make those patients happy. And I always say, well, Doc, when I had monovision with my contacts, it wasn't quite like this. I could hold it in a little bit different areas. With the extended depth of focus, you tend to get a little bit more of that. Like Shamik discussed, with any of these lenses, though, there are slight trade-offs. And what's interesting, you go back, this is the brochure from the Technis IOL that was back, actually, it was one of the first lenses we used when they launched it. They're coming up on their 20th year. It was launched in 2001, 2002, and our practice was was the first in the area to use it, and it was this big splash. Monica Robbins came in and videoed my dad and I using it, and it was this big change. And what was new about it was it corrected all the spherical aberration inside the eye, so it gave really high quality vision. They did some studies that it increased, stopping distance. Patients when driving their car could see cars further in front of them and see it and have that better contrast. But what they notice is when you had that pristine vision, you tend to lose all depth of focus. So you kind of are trading these two things. So as great as all the extended depth of focus lenses are, you're probably giving away a little bit of quality. Maybe it's hard to even measure. You have to really get scientific. So you kind of weigh these two things. You want to correct all the spherical aberration, get really pristine vision, or you want to leave some in the system to get that depth of focus. So that's just sort of...
And another way you can deal with that trade-off is sometimes you can even do some mixing and matching. So let's say you take a patient and take their dominant eye, and maybe with the dominant eye you want to get that high-quality vision with a traditional monofocal, and maybe in the non-dominant eye you go for more of an EDOF lens that may be off. So there's many ways that you can skin a cat in terms of figuring out how exactly you want to make. And I'm not saying we always mix and match, but it just makes you realize that there's each lens has pluses and minuses associated with it.
Right. So that's we kind of covered that one pretty well. The next category, or next type of lens within this category of diffractive optic. Often, if you see this lens, you're thinking, "Oh, this is a multifocal lens." In actuality, there is a diffractive optic that's classified as an extended depth of focus. The Symphony lens was launched that way. And then, Shamik, you might want to talk about the new Synergy lens at this point.
Yeah, exactly. I mean, basically, what Symphony is this diffractive IOL that goes ahead and gives extended range of vision. And patients loved it in the fact that you've got great distance vision. You also have some intermediate, and then probably a little bit more intermediate than what the Eyehance does. But with the diffractive optic, at night, there is a slight potential as far as dysphotopsia is concerned. Another lens that J&J has recently introduced is called Synergy that you'll start to see in some of your patients. And basically what they've done with J&J is kind of created a hybrid lens where they've basically combined technologies, an EDOF lens, as well as what typically would have been their ZM-BU lens, the lens that gave them very good up-close vision. So with the Synergy lens, what we have is on one part of the profile, it's more of an EDOF where we've got extended vision, and on the other end of the profile, you've got more of the very up-close vision. So this lens potentially has the greatest range of vision of any other lens that's out there, per se. It also is very pupillary independent, so it doesn't matter as much how much light you have. So again, utilization of diffractive optics with the Symphony, you can combine these technologies to try to improve that.
Yeah. Proprietary or zonal EDOF. So there's a few lenses that fit in this category. You have Crystal Lens HD, we no longer really see that, but that had a little zone of central near. The light adjustable lens were involved in a study where we can use the light adjustment and induce a small zone in the center of the lens to give some depth of focus. The Vivity IOL also has a central zone or optic, and that's another extended depth of focus lens that we've had a lot of success with. Again, it's probably a little closer on the range, or at least the price point is closer to a multifocal lens, but it doesn't tend to have the side effects that the multifocals have, and so we've had good success with this lens within the practice, and you can see it's got a nice depth of focus curve. And then the last category of EDOF is called the Aperture Optic, and we were involved with a study that finished up with the FDA just within the past year. It's being submitted, hopefully be approved within the next year. And this is...
so what's interesting about this is you've probably seen some of our patients that had the camera inlay inside there. So what's novel about this technology is they've basically taken the camera inlay, not exactly the camera inlay, but they've kind of placed it within an IOL. Now this lens is currently available within Europe, and where a lot of our colleagues find a lot of utilization of this is because we really haven't split light with diffractive technology or done anything with it, but with the small aperture optics, if you think about it with photography, when you go ahead and create a small aperture, you basically increase depth of field. So potentially with this type of lens, a lot of patients that may have aberrated corneas, let's say patients with extensive RK, or maybe they're keratoconic eye. So those patients, it's very hard to find a lens that's going to, if someone has keratoconus, you don't exactly know how much astigmatism to correct for because it tends to be very much asymmetric. So that's potentially an area where this type of technology would be very useful.
Yeah. So again, when looking at all these lenses, we're always looking at that balance, sort of quality of vision versus quantity of vision, and understanding what's going to fit best for the patient. It's great times, but a lot of times you'll see these, the lenses come with, let's say, a great sales brochure. Patients will search the internet and they're like, doc, I want this lens. This is what I want. Look what the brochure says. It's going to give me all this vision. So we always have to be careful, as you've probably been burned. So I tend to just say, ignore everything you see on the brochure. All these lenses are great, but you've got to kind of temper the expectations because each eye is different. And a lot of times patients seem that have the highest expectations, maybe have a compromised eye or the complicated eye. It can be challenging to meet. So we always have to be careful with that and kind of set those expectations. But we'll go through it again, the same case, but let's say, 6-year-old presbyopic, history of monovision, and now you learn that they have a history of LASIK. What's going to be your lens of choice? And Shamik, I don't know what your thoughts are, on these patients. But
Yeah, I mean, for me, if someone has had myopic LASIK, I mean, my go-to lens, if they want to have extended depth of field, is more the eye-hands lens, like I mentioned earlier, just because it's got this great defocus curve that basically helps us figure things out. But again, if someone has had hyperopic LASIK, to your point, then you may look at consider another technology there.
That's right. So we tend to go with the Rayner lens if they've had hyperopic LASIK. So in a normal eye, you pretty much have a number of lenses that you can choose from that they're going to likely achieve the patient's goal. Prior hyperopic LASIK, that steep central cornea, we're going to lean towards either the Rayner lens or maybe the B&L lens, which doesn't impart any aberration. It's called aberration free, and at that point you might maintain what that patient's optics like. If they sort of like their optics from their LASIK, we'll leave it be and use more of a B&L lens. Post-myopic LASIK, like Shamik said, maybe a B&L lens if they want to keep it, if they like their optics, or an eye-enhanced lens.
And another thing, when you look at the topographies, a lot really comes down to when was the LASIK performed, in the sense that a lot of older generation ablation patterns were not as symmetrically performed. It's not as clear cut. So if you've got an asymmetric profile, that may be a case where maybe it's hard to necessarily neutralize that, and you may want to go with more of a neutral type of aberrated lens. Whereas if it's more centrally, like if someone had LASIK more recently, those ablations tend to be pretty centrally located. You may be more apt to go ahead with more of like a eye-hands type lens. I'll go ahead and correct for that.
Yeah, I agree. Post-RK, right now we might use an eye-hands. It's acting a little bit more of a positive spherical aberration eye, so you can drop in an eye-hands that can kind of counterbalance that. Hopefully soon we'll have the IC8, which is this Aperture Optic, and sort of taking a regular cornea and now give them something. Not a lot of the lenses that are on the market kind of add aberrations to the system. The Pinhole is the only lens on the market that's going to take away aberrations and more or less maybe give them a little bit more clear. Yeah, Kathy. Right.
That's a great question, actually. In fact, in Europe, when it came out, they basically said that you should do this in one eye only and keep the other eye straight. But we actually know of some colleagues that have actually decided that this lens works so well, they'll place in both eyes. So it's no, more like keratoconics or patients that have aberrated eyes.
Yeah, that's a good point. Most of the patients that, when they first tried this one eye, they like this eye so much better than the other eye. They're like, why can't I have it in both eyes? So, so it's interesting. So it's probably, if they have an aberrated cornea, it'd probably be going in both eyes. Yeah, it's a good question. Glaucoma, these are a tough call. A lot of the patients might really want a fancy lens, but you might think to yourself, should we really be in the market to trying to extend that depth of focus, take away any quality? Maybe you just want to go for the best quality of vision, looking back to that Technis, original Technis ad that neutralized all spherical aberration, and try to get the best quality of vision. You can keep that in mind. In general, our thought is astigmatism correction is always a good idea. You never really can go wrong with correcting the astigmatism, but adding other aberrations into the system with a multifocality or whatever, not to say we can't do it, but you have to be cautious about considering that. Loose zonules, like I discussed, if there's something wrong with the eye, if they have pseudoexfoliation where the lens might decenter a little bit, if they have trauma, again, some of the lenses are sensitive to centration, so maybe we'll use a B&L lens that doesn't have any aberrations in it, and so it tends to be more forgiving to decentration.
Sure, and then retinal pathology, I mean, basically we know that with retina, you talk to patients, let them know that besides their cataract, they have this other pathology. So number one, you have to go ahead and have a discussion with them to let them know that removing the cataract will not necessarily get you to 20/20 vision. It will improve your vision, but you may have some limitation. The real question comes down to if, let's say you have a patient that has AMD, macular degeneration, and they've got 3 diopters of astigmatism. What would you do in that situation? And if you think about it, like Bill mentioned, there truly is no harm in correcting astigmatism. If you can correct astigmatism, you can get patients to see much better. So from a medical perspective, definitely it makes complete sense to go and correct the astigmatism. However, we live in a time that's not just you consider medical issues, but you also think of financial issues. And many times, if someone wants to have their astigmatism corrected, you have to go ahead and pay additional dollars out of pocket. That's perfectly fine also from a medical perspective, but many times, as soon as patients go ahead and put out extra dollars, they somehow have selective memory loss, where even though you've gone ahead and told them that your retina may limit your vision, they kind of feel that, well, I paid this extra $2,000, that should potentially correct my macular degeneration as well, and they may come back being potentially unhappy. So not saying that one should not correct astigmatism, but I do feel that if one goes ahead in that situation, you have to have a frank discussion with the patient. And again, I have some patients that truly understand it, and I'll go ahead and correct the astigmatism. But there's some patients that you talk to them and you realize, well, no, I better just put in a monofocal. I don't think this patient's someone that's going to really appreciate what I'm talking about. And I think we all have patients like that where we have to really understand. And those patients, I mean, that's part of the art of co-managing, obviously, is that you guys have been dealing with these patients for such a long time frame. We're meeting them for a very selective period of time, but that's where your input is very helpful to us to let us know that what will actually work well with this type of patient.
Yeah, yeah, great point, great point. And you know, correcting astigmatism, you probably have those patients that have 3 diopters of astigmatism, and you have to remake their lenses like how many times? If they tilt it just a little bit, like, doc, it's not working. You're like, well, you've tilted your lenses there, and now we have to remake them. So correcting astigmatism, a lot of times patients, they'll say, they're like, doc, I love my glasses, I love my frames, you know, I like the way I look, I hide my wrinkles. I say, okay, that's fine, but if we correct your astigmatism, we can make it an easier job. Is sometimes, like, literally, I just saw a patient the other day, had 5 diopters of astigmatism, loved their glasses, didn't want to get out of them. I'm like, well, do you ever have to remake your glasses? Like, yeah, all the time. They come in and they're not quite right, they remake them. If we have the ability to correct the astigmatism, it can make, you know, kind of your job easier. Now they drop them from $5 a seal down to a diopter a seal or something like that. Still wear their cool glasses, but at least it makes the job easier. The chance of having to remake those becomes much less. So sometimes we'll talk about that. I used to just say, like, oh, if you like glasses, why even correct it? But I realize it can be an opportunity to make it an easier glasses fit at that point.
Yeah, it's more of a quality issue in the sense that if you wear contact lenses, I mean, it's not, or even glasses, you may not always have it, right? And again, glasses work well as long as you're looking right through that center part. But if you're looking from the side, your optics are aberrated overall. Whereas if you have an IOL that is closer to the nodal point of the eye, you ultimately will have a more pristine level of vision. So the analogy I like to give patients when they have a lot of astigmatism is that you can have standard definition vision if you don't correct your astigmatism, but if we have the opportunity of correcting it with an IOL, that potentially can give patients more like high definition vision, a much higher quality vision. So you can still wear your glasses, to Bill's point, but the overall quality with those new pair of glasses will be significantly better than otherwise.
Yeah, good point. Let's see. So, you know, in summary, you know, we've got a lot of great options for IOLs. You have to understand your patient's goals. There's definitely opportunities to advance or enhance the visual function, but we have to understand what the technology can and can't do, and understand that with all technologies, there's sort of advantages and disadvantages. Like Shamik said, there's no perfect lens. We're working on it, but certainly it's nice to have more tools in the toolbox at this point. And so it's been an exciting time over the past year or two to have all these new lens options. So let's kind of summarize those, and we can sort of open the floor to questions about this or cataract surgery in general or any of the new lenses, but happy to talk about that.
Go ahead.
Yeah, good question. I think if it's a totally normal eye, you know, there's really not necessarily a wrong choice there. So we might look at what power of lens do they require. What's, you know, what do we have, you know, in their power? Some lenses have a different consignment diopters or things like that. Do they have astigmatism or not?
It also comes down to what is the patient's goals, in the sense that are they someone that wants to have a greater range of vision and they're willing to tolerate some degree of dysphotopsia? Well, in that case, some type of diffractive technology like a Synergy may be very valuable inside there. On the other hand, if someone wants to have some extended range of vision but does not want to deal with any type of dysphotopsias, wants to have a better quality of vision, that's where more of an EDOF type of lens may be more valuable. So a little bit of positive, yes. It's about 0.2-ish or so. Typically you want to cancel that, but again, a lot of these lenses will have some degree of negative spherical aberration. The majority of lenses have, there's some that are neutral, most tend to have some negative. There's few numbers that actually have positive spherical aberration.
Looking back at this slide, a lot of people will ask, like, well, do you use these new extended depth of focus in your basic cataract patients, and just to try to get an extended depth of focus? In general, we're not using them per se in the basic patients. You can look at, you know, to really achieve a patient's outcome, you've got to correct the lower order aberrations. That third line, you've got to correct sphere, you've got to correct cylinder, and spherical aberration is sort of a later consideration further down. And if you haven't corrected the first two, whatever we do with spherical aberration is really not going to mean much. If they're -1 or +1, a little bit of spherical aberration is not going to mean much if we've missed the target, if we've left a buccal or something like that. So, you know, we tend to use these lenses in our driving and multifocal packages where we're using intraoperative aberrometry, maybe using femto or whatever we might use, using all our tools to hit the patient's goals and hit their targets, and then spherical aberration can come into play. So if you're way off target on the lower order aberrations, it's not going to mean a lot to kind of add in spherical aberration. So that's one point. You know, all these lenses we talked about are kind of more available in our you know, upgraded packages, just because we've got to use all the tools to kind of maximize what we're getting. Yeah.
Any other questions?
Yeah.
So in the past, and then we will be recommend multifocal
Sure.
because it became monocular. There was a lot of problems with only one eye. They only worked well with two eyes. Is this better as far as that kind of appear?
Yeah, I mean, I feel like, actually, to your point, even if someone is monocular, you can actually achieve great vision even with a diffractive optic like a multifocal, but it really comes down to what the expectation. I think the big change that's happened is in the past we would go ahead and if someone wanted greater range of vision and they were intolerant to any type of night dysphotopsias, we would shy away and go straight to a monofocal. However, these days, the beauty is that we've got these choices available where, let's say I've got someone that wants to have a greater range of vision, but they're intolerant to any type of night vision. They say, Doc, I want to have pristine, I don't want to have any glare, halos, things of that nature. Well, then we've got many other options available that we can go ahead and pay some dollars, get an extended range of vision, and achieve that. And if necessary, we can actually do a little offset, like where I like to call it, not quite monovision, but more of like blended vision, where it's maybe a little bit of defocus in the non-dominant eye to achieve a greater range of vision. So I would say that with the newer lenses we have there, we can basically be able to satisfy those type of patients.
Yeah, that's a great point. So, yeah.
Okay, yeah.
I apologize. I've got to run and catch a flight. I'm going to New York to give a talk on similar subjects here. So, anyways, but great to see you all. It's been great to see you in person. So nice to have, you know, a live meeting. Thanks for sharing our patients and with you all. It's been a great relationship, so we truly appreciate it. Got a great lineup tonight, and so enjoy this evening, and good to see you all. Thank you. Thank you.
Yeah. Any other questions regarding the IOL topic? If not, we'll turn things over to Dr. Pierre, right? Is he? I didn't see him. There you are. Perfect.
If everybody
Awesome.
wants to get up and get something to eat before Dr. Pierre comes up and speaks, or get another drink, or or there's dessert around the corner to the right here. Help yourself, and then Dr. Pierre will start in about 3 minutes.
It's a good talk. Thanks.
Oh, thank you. Yeah.
I feel like I probably benefited from that like more than everybody else.
Even I did, actually. Once I was listening to it, I kind of got a better perspective on certain things.
I don't know much about the Synergize one. Is that the new version?
That's a new one from Synergy is basically the competitor to Panoptics.
Okay.
Inside that.
Okay.
So
you guys didn't talk about the Panoptics very much.
the talk wasn't sponsored by so we had to be a little politically correct.
Understood.
Yeah.
Understood.
So that's why we mentioned Rayner a lot. We mentioned J&J a lot, stuff like that.
Okay, cool.
I
Is Rayner
personally-
and J&J related?
No, they're two different companies. So they basically split the cost. as far
Oh,
as-
did they? Okay,
Yeah,
okay.
so that's why we kind of brought that.
I
But
appreciate it.
Panoptics and Synergy are basically competitors.
Mm-hmm.
I think both of, in my mind, I don't know if one is necessarily, I'm still trying to figure out if I feel one is better than the
Right.
other inside there. They say that Synergy is supposed to give a greater range, but in my opinion, I feel like it may potentially have a little bit more dysphotopsia than a Panoptic.
Okay.
So I've been a little hesitant. I've been very happy with the Panoptic and didn't, so I've been hesitant to do that. I mean, I didn't want to say that in front of the J&J
course,
folks,
of
but that's what I understand, is that if someone's like a -8 and they're used to holding things over here, the Synergy can achieve that, whereas Panoptics is more like this.
Okay,
But again, this is not really physiologic.
Right,
This
right.
is more physiologic. So
That's habitual.
yeah, that's habitual. So it may be more that
Put him in the conference room.
if someone wants something, like let's say you have a higher myope that wants, that may be one place where I may lean towards that lens
Okay.
over the Panoptic.
Okay.
But
Do we have
otherwise,
the
like,
full consignment though at the service centers?
yeah, we don't. Right. And the reps are over here, so if you want to try it out or stuff like that, they'd be more than happy to have you
Cool.
try that out inside there. But basically what they did with Synergy is it's a hybrid lens where they combine the Symphony. What program is this, by the way?
This is just PowerPoint.
But how do you get it to come like this? Because to me, this was such. I love the fact I could see the time. I could see the next slide.
Yeah, what view is
What
that?
view is this? I've not seen this with PowerPoint.
So I think it's
I'm
the
used to seeing the
newer
PowerPoint where it has the whole thing.
presentation view. So let's load your presentation up, Dr. Pierre.
Is the Dropbox stuff all downloaded to the laptop?
Yeah, so your
All my
videos are all in that folder right
So
there.
I will put those on there, and you're going to do that from your side to the online crowd?
I'm not certain that we'll be able to do it for the online crowd, but we'll capture it off the TV here.
Okay, sounds good.
So, but all your slides will get
So
to
you
the
go to
online
Power.
crowd.
So you go that's PowerPoint. I want to see how you do this. Okay, now what do? You go to.
And hit this up here. And
No,
then
but how do you get
Yeah,
this?
how is this view?
Because I like the fact I got my
It's
next
called,
slide.
it's called presenter's view.
yeah, so it should just be at the very top of
Go back to minimizing it.
yeah, so
So
right up here.
normally I go to like slideshow, and I go start from beginning. But this is an extra icon.
Yeah, so
Is it anywhere over here?
Here, hit slideshow and see what happens. Maybe get a menu.
From beginning, from current slide.
Oh, yeah.
I don't see that.
yeah, so it's just this little icon up here. So,
So is this on all versions, or is
Oh.
that just on a newer version?
I think it's on the newest version.
Don't you love? I mean, the fact
Yeah,
is,
it's-
I could
like
see what
having
time it
scenes
was.
going up. Yeah,
I could see what was coming up next. I mean, this was, and it comes up full like that.
that's pretty cool.
So, okay, no, I learned something. I did not realize that. Okay. Perfect.
Cool. spot so we can keep things on time so that nobody's here too late. Although I am happy to see people fellowshipping with each other and in person and having a good time. It is really nice to be together again. This talk that I'm giving is actually sort of similar to a talk that I gave a couple of years ago, but you know, it's been a couple of years, and I don't know about you, but I forget stuff unless it's repeated to me. So I'm going to, on this talk about Yag Vitrolysis, I'm going to focus a little bit more on like selection. And that'll be really important for deciding on what we actually do with these floaters. So again, for those of you who don't know me, I'm Dr. Pierre. If you haven't seen me in a real long time, I look probably a little bit different. You know, just trying to keep up with Wiley and Bafna, I had to think so hard all the time that I was getting overheated, so I just had to get rid of some insulation. So just to keep up with those guys. All right, so let's talk about Yag Vitrolysis. I love this procedure. You know me, I love everything that I do, but I really love this procedure. It's so effective. My patients tell me how happy they are afterwards, and it's just so minimally invasive. And you know, ophthalmologists, we love to make stuff look easy that works really well right away and makes people happy like instantly. That's what we love. We don't always get it, but that's what we love. And so this procedure helps us do that. So I love talking about it, of course. Okay, so floaters. We all have patients that have floaters that are super annoyed by them. And again, in the previous talks, I've talked all about like the different philosophies of how we address them. Of course, the three options that we have with floaters are do nothing and tell the patients you'll probably neuroadapt them, and they probably will. There are those floaters, of course, that are too big to neuroadapt to. And there are those brains that won't neuroadapt anything because they're too persnickety, is the word that I like to use. But what we shouldn't be doing is just blowing them off and dismissing all of them, right? Because there are some patients that they might not mention it, but they're like, yeah, man, that is really significantly bothersome. So if you see floaters, it's good to at least talk about them and more than just ignoring them. I remember when I was in training, you know, they told us, you know, didn't teach us anything at all about floaters. They said, oh, floaters, oh yeah, just tell the patient that they're going to ignore that, which is not necessarily true. But, you know, most people do, but it's not true for everybody. And we just blew them off. And they didn't even really teach us how to examine them and all the different kinds and flavors and locations that there are until I really got into dealing with floaters, and I realized, oh, there's a whole world of excitement here to be discovered and described here. So again, the other options are Yag Vitrolysis, not very common. I've been doing it since the very beginning of 2017, so that's 57 months, and I'm still doing it because I still like it. I still think it's a great procedure. I'm a little surprised that it's not caught on a little bit more. I think I still might be the only guy around doing it. But I think it's because the laser is just quite expensive, and a lot of ophthalmologists are not wanting to make the investment to buy that. But we've got it, and so I use it all the time. Yag Vitrolysis, of course, is often overlooked, but it's this nice minimally invasive procedure, but it's kind of specific as to which floaters it can treat, hence the topic that we're talking about tonight. The other option, of course, is the pars plana vitrectomy. It's a much more common procedure for floaters, and it's more invasive than the laser, obviously, but it is surgery, and even pars plana vitrectomy is a really great procedure. I don't do that, obviously. I'll send them over to the retina associates for that. And they've got it technology-wise honed down to a great procedure that's not a whole lot more invasive than cataract surgery, of course. So those are our three options that we're talking about for dealing with these floaters. Again, Yag Vitrolysis it's just as successful as patient selection. I have a very high success rate and a super low complication rate. Why? Because I'm super picky. You guys who know, and those of you who know me well, I'm just a little bit OCD about things, and I'm very picky about what the floaters that I'll treat with this laser. And I have a very low threshold if I don't like the look of it to send it to retina associates. So they like me pretty good. But the thing about the retina associates is they're all trustworthy, and having a good relationship with them, if they know that I have sent them a patient for floaters that they're not a Yag Vitrolysis candidate, you know, it's about 99% chance that they're going to go ahead and proceed with doing the vitrectomy. I'm not going to send them a patient that I don't think should have anything done at all, or I'm not just going to punt them for a patient that, you know, just doesn't need to have a floater addressed. So they know that if they're getting a patient from me, it's been well vetted for them. And if I can sort of transfer the skills that I've developed in assessing floaters to you guys in a talk like this, then they will know that, okay, this doctor is sending me a floater. Okay, I know for pretty sure that this is going to end up being a pars plana vitrectomy because that doctor knows their stuff, okay? So if you're just uncertain about floaters, then, you know, just start with one of us, either retina associates, or it's more appropriate for pars plana vitrectomy, I'll send it to them next, and you'll get a letter that says so. Or they'll send a patient to me for Yag Vitrolysis, which happens once in a while, and we'll figure it out. But it's sort of nice to just be able to save the patient a step, an office visit, just overall reducing load on the medical system, right? So again, how does Yag Vitrolysis work? What is the mechanism? The Yag laser is a cutting laser, okay? It makes this tiny little micro explosion that has a little shock wave surrounding it, and it cuts things, okay? Snip, snip, snip. And basically, just like we do with the capsule, for when we do a Yag capsulotomy, we're making tiny little cuts in the capsule and basically opening it, making a posterior capsule rhexis. I'm doing this just much deeper inside the eye and cutting up the floater into small bits. You'll hear different doctors that talk about Yag Vitrolysis say different things because there's lots of different philosophies on how to use Yag Vitrolysis. I have a very simple philosophy. I just consider that the laser cuts it up into small pieces. You'll hear people talking about like vaporizing it over like, you know, 20 sessions at however much money each that they can charge, and then until it's all gone and you can't do too much. And, you know, that's not my philosophy. My philosophy is do it once, have insurance pay for it. If it works, great. If it doesn't work, then off to Yag Vitrolysis, but no gouging of patients and no over-promising what the laser can't do, okay? So I'm cutting a large chunky floater with a big shadow into smaller fragments that are with smaller shadows that are much more easier to ignore, or neuroadaptable, if you want to use the fancy phrase. So again, the laser, it's not like a heat laser that just goes straight, hits what it hits, and then gives off like a heat burn. It's a cutting laser. It's focused at a particular point, and then right where the laser is focused, that's where it exerts this little explosion. And then behind that, as the laser continues to travel, there's really no energy that's dispersed at all. So that's why it's safe for me to make this small explosion right in front of the retina, because any laser energy beyond that is dispersed, and the retina is not absorbing that laser, okay? Again, just the same exact way that we do for Yag capsulotomy. When I'm making my little micro explosions there, I want to cut the floater and nothing else. So in order to do that, I've got to make sure that I have this sort of a very good conceptualization when I'm looking in the eye, and I'm seeing exactly where I am, and thankfully the optics on the laser are supremely good. And I can tell exactly where I'm at, and I need to stay a certain distance from the retina. I need to stay a certain distance from the lens, if they're phakic. If they're pseudophakic, it doesn't matter too much, right? So I always keep this safety zone in mind, and as you guys are evaluating floaters, then you can learn how to do that as well. You guys already know about pars plana vitrectomy and what that is. I always compare it when I'm talking to the patients that I end up sending for pars plana vitrectomy. A lot of them have had cataract surgery before. And I say, well, you know what cataract surgery was. Do you remember how it was? It wasn't a really big deal, was it? Yeah, they make a little port in the cornea here, a little port in the cornea there. They basically vacuum out the cloudy cataract, and they replace it with a brand new clear lens. And the pars plana vitrectomy is not much different. They make a little port in the pars plana just adjacent to the cornea. They make another little port, and they vacuum out all the cloudy floater stuff, and then they replace it with brand new clear fluid that stays clear forever. And then most patients realize, okay, well, okay, that sounds reasonable. If that's what I need to have done, then that's what I need to have done. But this is the gold standard for just definitive removal of the floater. Remember, the laser does not remove it, it modifies it, okay? But for removing it, this is the pars plana vitrectomy for that, and it's done by the retina guys. It's minimally invasive. It's like, at this point, 25, 27 gauge instruments, which are basically doesn't mean much to you, but it's really small, really thin instruments, okay? They used to be doing things like 20 gauge or even 18 gauge, which is it's much thicker holes that would require sutures. Now they go in, and a lot of these ports are just sutureless for them as well. And that just evacuates the floater. Again, it's low risk. It's even lower risk than it used to be, but it's still surgery, still has higher costs, still with the follow-up and the incisions and the infection risk and things like that. But it's quite good. And this is the best choice for certain floater types, as we will discuss. So whenever we're thinking about different treatment modalities, lots of different options, and we're trying to personalize the individual patient in their history, in the context of their eyes, we have to sort of go through a very careful thought process to help pick just the right thing for that patient, okay? But basically just try to simplify things and just pick the treatment that will be best for that patient in their time with their expectations, okay? And you got to consider not just the patient's eye and not just their history, but the psychology of it too. Like, what is their expectation level? Or do they want to be like absolutely done all the way with everything? They like everything once and done, and they're willing to go to all ends of the earth for it? Okay, maybe that sounds like a pars plana vitrectomy floater. Are they sort of the more timid patient that wants the least amount done and they want to stay away from surgery at all costs? Okay, then maybe we should start thinking about laser first, and that would be our our choice, and then they'll have to prove to us that that's the wrong one before we go and recommend like something a little bit more, okay? And again, when you're weighing risks and benefits, whether to do anything at all, remember that what the risks weigh on the little scale there. The risks don't weigh very heavy for each one. For Yag Vitrolysis, it's very, very, very low risk, and it's very quick and logistically simple. For the pars plana vitrectomy, it maybe weighs a little bit heavier on the scale, but it's still not a really heavy risk. The benefits, though, have to outweigh the risks in order for us to recommend the procedure, okay? And just remember that the more annoyed the patient is with the floater, that's the thing that makes the benefits weigh heavier, okay? Because they'll get rid of that heavy annoyance. You might see a really honking big floater in there, but if the patient's not annoyed by it, you might be the perfect candidate for one of these procedures here, but if they're not annoyed by it, then the risks actually outweigh the benefits. You might see this dinky little floater that looks like nobody should be annoyed by that, and yet the patient's like really bothered by that. And so that might actually make this little tiny wispy floater, getting rid of it or doing something about it, the benefits actually outweigh the risks for them, even though it doesn't seem like it should be that bothersome. Okay, so you have to consider the psychology of the patient as well. Talking about benefits for the Yag Vitrolysis, when we do the procedure, I always tell the patient, you're probably going to notice a difference right away. And most people notice that difference within the first week. It's very positive, and they're like, wow, this is great. They see me for the 1 week, or they see you for the 1 week post-op, and they're like, wow, this is great already, and they're happy. Some of them actually say, I think that there's more floaters now, and I tell them, don't worry, we just have to wait for the delayed improvements. I tell them to give their brain another 2 months, because your brain has to neuroadapt to the new configuration. And it might have a sort of a hard time with that at first, but give your brain a fair and square chance to do that, okay? And again, when you pick your patients correctly, the reports show that, more than 90% of patients, and I would say it's even higher than that, have a good success happy rate there, okay? But again, you're managing expectations with the Yag Vitrolysis. It's a functional improvement. We're saying we want to, okay, that you're not noticing it as much. You're still going to be able to find little pieces of debris maybe if you're sort of searching around on a bothersome. You shouldn't be swatting at flies when you're trying to drive, or, playing extra musical notes when you're playing your instrument. Usually don't try to repeat them and keep them coming back. So the benefits of this is just nice once and done. And again, the benefits of vitrolysis over the pars plana vitrectomy are it's less invasive as far as cost, logistics. There's no restrictions at all afterwards, and there's really no downtime at all. Very similar to a Yag capsulotomy. I don't even have them on drops at all. As far as the risks from Yag Vitrolysis, there's things that are written in textbooks, and then there's the things you see in real life. Okay, I'm going to sort of mention a little bit of both. Retinal tear and detachment. Could the laser get the retina? Yes, it could. Have I seen that in the past 57 months? Thankfully, no. Just kidding. But that's because, again, I'm very picky about who's a good candidate for it, okay? And it's less likely to cause any retinal pathology if the detachment process from the vitreous is already completely detached from the retina. If that process is complete, then I'm not going to put any traction on the retina when I'm sort of stirring things up in there with the laser. So this is why I like to wait, you know, 2 or 3 months after the onset of a PVD, both to let that detachment retinal or the vitreous detachment process complete, and to give them a chance to neuroadapt to it. Okay, so sometimes I'll get this patient and they have the floater for a week and they're already crazy by it. They're like, you know, Dr. Pierre, do something about it now. I was like, sorry, you just got to give your brain a chance. As far as hitting some structure on the anterior part of the eye, a posterior capsular tear or inducing a cataract. I've personally never seen a cataract really being induced by Yag Vitrolysis. Obviously in pseudofakes this is not a problem. Even if you inadvertently open the posterior capsule, I mean, well, save them getting a Yag later, and that's fine. There's really only going to be benefit from that. For phakic patients, it's not really an issue if you're hanging out in the right spot. So you know that safety zone slide I had up there? I might have a little increased safety zone buffer for the anterior part of the eye there and just stay far away. I would never target any anterior vitreous floaters in a phakic eye, but if I'm aiming at a Weiss ring that's way in the back, I don't have to worry about that at all. I've heard speak of and talked with people who have seen IOP spikes after that Yag Vitrolysis. I've personally never seen it. I guess the hypothesis of how it works is that, you know, you mobilize some proteins, the proteins come around the zonules, they clog the trabecular meshwork, especially if it's already poorly functioning. But again, I've not seen this before, so again, I'll have my radar up for it, but it's not going to be something common. What about other risks of Yag Vitrolysis? This would be the biggest one, so residual symptoms. If there are still bothersome symptoms from like just the small pieces of debris after the Yag Vitrolysis, after it's busted up into small little pieces, then again, if I see something targetable, then I might go back for a repeat laser. I've done repeat laser on a few patients, but I've never done like 3, 4, 5, 6 sessions. Okay, that's the modus operandum for other people who do this, but I'm not in that sort of business. And so if I try once and it's proving not to work, then I'll say, okay, good. We tried the first step. Let's go ahead and go over and get the pars plana vitrectomy. Okay, and again, usually that means that the patient's brain is just so persnickety or perfectionistic that it just refuses to neuroadapt anything, and it won't tolerate any floater at all, not even little pieces of them, not even if they're tiny and small in size. So then they want nothing else, nothing less than a perfectly clear vitreous cavity, and that's what the pars plana vitrectomy will get them. And like the slide says here, if that ends up being the case, I still don't consider that it was a waste of time or money, okay? Because if we're going to do something more invasive, it's nice to prove to the patient that, okay, yeah, it was worth going for the more invasive thing. You actually needed that. We tried the simple, easy, less invasive thing, less expensive thing first before moving on to the big guns, okay? Pars plana vitrectomy. The benefits of that one, we talked about it. It's definitive, removes all the floaters. It can deal with all types of floaters and in all locations. So the patient selection has to be, you don't have to think as hard. Okay, just whatever's there, it'll get rid of it. And other retinal pathology can also be simultaneously treated. If there's like a retinal hole or if there's a membrane that's on there, hey, they can peel that already. I've had a few patients that were great candidates for Yag Vitrolysis, but I saw that they have a membrane. And I'm like, you know what? Why don't I just have you see the retina guys, because they'll be able to do a two for one for you. And that way you can avoid the laser and just get the one thing, because you're probably going to need that membrane peeled anyways. The risks of pars plana vitrectomy, like I said, it's just more invasive. There's anesthesia involved, surgical complications, inflammation. They're on drops. It's more logistically complex, a little more costly. You have to think about insurance coverage, and then the operating room, and with restrictions after surgery, post-op medications. And then, of course, the big one, especially for the young patients that have floaters, is the induced cataract. Most people who are like in their 60s or so, inducing a cataract faster, that's really not a big deal. For people like in their 40s, that's something that you're going to want to think about. I'm in my 40s and I still have pretty good accommodation, and I want to hang on to that as long as I can. So I'm sure that they will as well. You can sort of turn things around a little bit if you're thinking about this, if you're thinking about inducing a cataract. Sometimes I'll actually tell the patient, great, we are going to induce a cataract. And you know who that's for? It's for your high myopes or your high hyperopes. And they've got all sorts of crazy refractive error. And again, I tell those patients, you know, pray for cataracts as early as you can get them, because then you'll get cataract surgery and you'll have a whole lot less, whatever, astigmatism, hyperopia, myopia, and that'll be a life changer for them. So sometimes that sort of turns the patients around, and you take that thing that was weighing as a risk on the scale, it becomes a benefit, and that might shift their decision making a little bit. Okay, so good candidates for Yag Vitrolysis. Okay, so of all the consultations that I get now, actually, you know, I might change that statistic there. I used to say 50-50 I would do Yag Vitrolysis, and then, or I would send to the retina associates. But I feel like a little bit more I've been getting more candidates that are perfect for the Yag Vitrolysis. So I think I've been sending to retina a little bit less with the way that the referral patterns that are coming in, and that's probably due to stuff like that we're doing right now, just talking about it, okay? There's a group of people who find me on their own, and then there's the group of people that are sent to me from inside the company, and then there's the people that you lovely people send me. But again, we can save the patient a step, some time, some money if the pre-screening process is optimized by finding out, okay, what kind of floater do you have and what's it good for, okay? I always tell the patients when they walk in the room, hey, did you read my little educational handout? That I make them all read before they see me, so that they know that there's lots of different kinds of floaters and different treatments for it. And I say, I'm just going to look at your eyes, and your eyes will tell me what to do, okay? So that they can't get mad at me for telling them something that they don't want to hear later. Their eyes are in charge, and so when you guys look, you'll be able to tell what the floaters are good for. A good Yag Vitrolysis, or any patient that is going to get the floater treated, a good candidate is one that's a symptomatic candidate. Like I said, if they're not bothered by it, don't even worry about it. And the symptoms have to correlate to the floater, not some other immediate opacity. Sometimes floaters can be sticky, and it can be hard to figure out, okay, this patient's got this blur. Is this blur like something from, like, is it surface disease? Is it something with, like, their lens or their cataract? Or is it an actual floater moving around? Or is it even something neurological? And sometimes it's sort of hard to figure things like that out. But if the better you can correlate the symptom to the floater, then the better it is that we'll do with the laser. They've got to be good dilators. I've been able to have some pretty good success even through small pupils, but please nothing like super pinhole-y. But it works better when I can get a good view. And of course, the older patients do better than the younger patients. If I see like a 40-year-old on my schedule for a Yag Vit consult, I'd be like, but I have done plenty of 40-year-olds that were like perfect candidates for this. So it's not a no-go. It's just less likely that they're going to be a good candidate. The 20-year-olds are never good candidates. So that's usually going to be pathology up here rather than right here if they're having floater symptoms. But I could be wrong. And also the older patients are going to be better candidates just because their vitreous is more liquid. And there's going to be more room for tangles and for treating in there. Less stiff, and I can move things off to the side better. Phakic versus pseudophakic. When I just first started this back in 2017, I only did pseudophakic eyes just to be careful, but I'm quite comfortable with phakic eyes. The only time that I would maybe say, hey, let's do cataract surgery first, if the cataract is dense enough that I'm not going to get a good view of the floater, or if it's going to block the laser from getting back there. But I don't want to ever risk a posterior capsular rupture. Can't even think about how I would address a cataract with a posterior capsular rupture before I even start the case, right? So I never want to put anybody into that position. But I'm quite comfortable doing Yag Vit on phakic eyes. Multifocal IOLs are okay. But like I said, if they need cataract surgery anyways, I might sort of just start with that and then do the floater afterwards. There have been patients with eyes that have a camera in it that, as you can imagine, that might make things a little hard to do with the Yag Vitrolysis, but I've been able to do it either through the ring, or I might approach from around the ring and get around it. But that's not a no-go, it's just a little harder. New onset versus chronic, we talked about this already. Wait till the vitreous detachment is complete and give them a chance to neuroadapt. So if it's been around for a longer time, it's better. Also, over time, that Weiss ring tends to migrate a little bit farther away from the retina. One of the things that makes them not a good candidate if that floater is like sitting right by the nerve. Of course, I'm not gonna brave to shoot at that. So if they've had a little bit of longer time for it to migrate away, then safety factor will be increased. Retinal detachment risk factors, lattice degeneration, high myopia, or if they've had a previous tear or detachment, they're still candidates. I'm still comfortable doing them. I'll just make sure that I take a real good look at that retina first beforehand. I just proceed cautiously, and I might turn the power down just a little bit. If they've got a real dense floater that I know is going to require me to turn the laser power up, I might say, okay, I think that I'd have to turn the power up too high for you. Maybe you would be a better candidate for that. So I keep it in mind about a few other factors as I weigh them together. The denser floater in a person with retinal detachment risk factors, I might shy away from that. And of course, the location. It's got to be easily visualized. It's got to be precisely located. The closer it is to the center of the visual axis, the better, or the more it's going to bother them, and the more likely they'll end up in your chair, right? And the better view that I will have of it. I find that most of them sit just a little bit inferiorly there, so when I'll like look right at the optic nerve, and I'll tell the patient in my high mag view to look down just a little bit, and that'll center the floater right in my view right there. It's got to be not too anterior for the phakic patients, as we talked about, not too close to the retina for everybody else. And the general rule of thumb is, how high do your guys' slit lamp mags go? Pretty good. So if you're under high magnification at your slit lamp, and you've got the floater in perfect view, and the retinal vasculature is out of focus, it's probably good. If both the floater and the retina are in focus at the same time under high mag, then it's probably not going to be good. Under low magnification, you get more depth of focus, and so you might have them both in the same view, in the same focus at the same time under low mag, but that doesn't mean that they're a bad candidate. So always zoom in on this when you're trying to figure out if this is going to be a good candidate for vitrolysis locationally. Floater type, ooh, sorry, the slide didn't transfer from Google Slides to this really well. Things are all over the place. So Weiss rings are the best. Weiss rings are good candidates for this, okay? Posterior capsular debris, say that they've had a Yag capsulotomy, and you see like there's a few little scrolls that are sort of dangling there in the visual axis right up the front. Those are good candidates too, because I can move those off to the side. Sometimes they're sort of caught up in some vitreous strands. They're the sort of stiff. But if I just lyse that vitreous, then it should push off to the side. Anterior vitreous synoresis. that sort of stringy stuff that right behind the lens, you have the patient sort of look around and it sort of swishes around like seaweed. That usually does not respond that well to Yag Vitrolysis, especially if it's the really cloudy stuff. I'll show you a video later. Just shooting into it does nothing. I always compare it to, for the patients, I always say it's like me going into the middle of the room. If the room was filled with smoke, I'm swishing my hands around. Am I going to make the room less cloudy, less smoky? No, I'll move the smoke around a little bit, but I'm not really going to decrease that. And then I'll talk to them about opening the window, opening the door, and putting fans to blow new air in. And they said, we just talked about pars plana vitrectomy, okay? If they're pseudophakic, though, and I'm going after a Weiss ring floater, and they have some of that anterior Vitreous, then while I'm there, of course, I'm going to go ahead and see if I can at least mobilize that stuff. I'll do like a grid pattern. I'm going to show you a video of this later. A little grid pattern in the anterior vitreous just to see if I can mobilize things up. And sometimes there's like a little isolated strand that's maybe just sort of dangling right in the visual axis. And if I can clip that right here, sometimes it just sinks down. So anterior Vitreous, if they're pseudophakic, then maybe I can do something, but only if I'm doing something with the other floater as well. Asteroid, it's useless for, and I'd be there all day for that one, right? And vitreous hemorrhage, of course not. And then these sort of like cloudy, diffuse debris that's everywhere, like I said, it doesn't work for that at all. That's, as soon as I see that, then I start preparing in my mind to talk to the patient about pars plana vitrectomy. The hard part there is sometimes patients have like some cloudy masses that are really not that symptomatic, but the Weiss ring ones, that sort of the speck and black dot symptoms, are more symptomatic. And if they're talking more about speck symptoms, specks and lines, than like a cloudy blur, then I'll say, okay, maybe we will start with Yag Vitrolysis and we'll just address that one. I made up my own grading system for these PVD masses. Again, when I was in training, you write floaters, and that's it. Okay, if they have them, then you don't write anything usually. But there's, like I said, there's so many different ways to think about these floaters and describe them. So for these Weiss rings, I'll write it down, okay, is it like a ring or is it like a little globe? Sometimes you'll see like a perfectly round one that's sort of whitish, and it looks like a little balloon filled with white stuff. More classic, of course, is the ring. So I'll write down the type, and then I'll call out to my scribe, is it small, medium, or large? Because there's a big difference. You guys have seen them. You've seen some big floaters, and then sometimes they're really dinky. Okay, wow, have I been talking that long? I haven't even got the videos yet. I described the XY location, like how far it is superior, inferior, nasal, temporal, and then the Z location, that is how close or far away it is from you. Like, is it close to retina? Is it right in the border zone where I'm not sure? Or is it far away from the retina? And then is it associated with like a mid-vit strand? Sometimes you'll see this floater and then there's this strand sort of coming at you in the view there. Here's a couple of classic pictures of Weiss rings. Again, these are the sorts of things that do well with Yag Vitrolysis, okay? It's fun whenever I do this, I always take a picture of the before. I don't bother taking a picture of the after for the patient because there's really nothing much to take a picture of. But the patient will like turn around and look at the big TV on the wall after I've shot their floaters and be like, oh, great, now I know what it looks like. Here's a picture of some Weiss rings here. The one on the left is a big one, but it's sort of wispy. That one responded really, really well. The one on the left there, you can see that one's a little bit denser, so I would describe that as a dense one. That's the kind that I would have to turn the laser up a little higher for, and I may or may not have success for that one. And again, if that denser one was in like a retinal detachment risk eye, I'd probably say, I don't want to use that much power on you. Here's another few classic Weiss rings. We got some videos. Do I need to cue those up, or do you?
Just go for it.
Don't worry about it.
Yeah,
I'm out of time anyways.
use the PowerPoint and then load it from.
Okay, fair enough. All right. Examining the anterior vitreous. Okay, this is important here. Okay, I do this little flick examination. So basically, this is right behind the lens. This is for looking at those anterior wispy ones and see, okay, are these ones going to be the culprit or not? So with no lens in place, you just bring your slit lamp up in place, throw your beam from about 30 degrees off to the side, and you get sort of at a higher magnification, and you're doing a dynamic exam to see these floaters in motion, okay? So the floaters that they're talking about, you might look in there and not see them because they're hanging out down here now, but as soon as they move their eyes, it's like, and it sort of goes across their visual axis. And that's when when they're bothered by it, and it might hang out there for a long time. So I'll have them look up and then straight ahead, left, straight ahead, down, straight ahead, right, straight ahead, and I'll watch that stuff just swish all over the place in there. And usually it's when they're looking down and straight ahead, you'll see this thing sort of come up and do the wave, and then sort of slowly come down. And then I'll say to the patient, wow, yeah, that does look annoying. And they always appreciate when you can see what they see. They always love that feedback. And so I call that the flick examination. And then grading those, there's lots of different things that you can see there. So there's the anterior vitreous synoresis, just the tangly strings that you've all seen. They're sort of white, and I'll grade it from 1 to 4 plus. And then a lot of times they'll have these sort of cottage cheesy curds that are in there, or you might even call it like a cat tail. So you ever seen a cat that's really mad? It's got its tail straight up and it's all fluffed out. It's a common pattern to see one of those cat tail things just come up and it's like screech in the middle of the view. And so I call that a prominent opacity. Sometimes the whole anterior vitreous just looks diffusely thick. And so I'll describe that. Or you might have these isolated strands that I talked about, or you might see some PCO debris in the visual axis. Well, I'll just email out the videos or make them available. You guys can all watch them later. Poor candidates, of course, are the wrong type of floaters. We talked about this already. Yeah, this is our review. Poor dilation, young patients. Okay, and then referring to the retina associates, and good. So, like I said, even if I end up sending to the retina associates, it's not a waste of time. I talk to the patients probably more than the retina guys do, and so they've had a good, thorough discussion about it, so that by the time they get to the retina associates, they know exactly what to do, and they're comfortable with the plan already. So it improves patient confidence. Okay. So with regard to the videos, I'll make those guys available to you guys so you can see. There's some videos of the actual procedure. You can see the floaters blow up and sort of dance. It's like the cowboy movies. I'm like shooting at the feet, dance, and it's they sort of dance around until they crumble apart. And it's like picking at a knot, and they just crumble before your eyes, and it's quite beautiful. And then you have a little victory celebration with the patient when you're done. But the videos will show you what you want to see, and I'll make sure that those are available. Question, I saw.
Yeah, other than the density of the vitreous of the younger patient that didn't catch, would you say that the younger patients at current points do worse with the YAG?
No, they're usually not good candidates for the Yag Vitrolysis because their vitreous is stiff. So if they do have some opacities in there that I can't fracture up, or I can't even really mobilize them. Because even if I shoot that, then it's like it's going to stay put still. Meanwhile, the liquefied vitreous, if I shoot that, whoosh, swish, and that should mobilize things off to the side more. So part of the way that the laser works is not just fracturing them and fragmenting them, it's peripheralizing them, because that will be helpful for the patient too.
So that was the reason.
Yes, yes. More questions? Right, very good. Sorry about the videos. I'm all so long-winded. That's so short. I was even going to bring a live patient in here for you guys to see. I had 3 recruited, but I'm like, I don't have enough time for that. So I called them and told them not to come. So who's up next?
Dr. Davis.
All right, Dr. Davis.
If anybody wants to take 2 minutes to go grab something else to drink, use the restroom, feel free to get up and about.
Thanks for your attention.
Yeah, good. Okay. So, hi everyone. I'm Rachel Davis. I'm the new oculoplastic surgeon, and I come to this office pretty frequently, but you can see that I go to a lot of different offices, so I'm all over the place. I do anything from lids to tear drainage surgeries to thyroid eye disease management. So I've got a pretty wide array of things that I do, and I've already seen consults from some of you, so thank you for sending them over. When I was putting this talk together, I was trying to figure out a way to make things a little bit more engaging, and when people do these things, they usually put pictures of their pets or their kids, and I don't have either of those. So this is my husband, and keeping things seasonal. This is us pumpkin carving a couple years ago, and in case you cared, those are our final products. We were very proud of them. But back onto what we're going to talk about. So the goal of my talk today, we're going to talk about a couple of different topics in oculoplastics. So we're going to talk about lid lesions, which is one of the bread and butter things that I see from a lot of people. We'll talk about some medical management of a couple of those. We'll look at some droopy lid cases, differences between brow ptosis and dermatochalasis, which can be kind of tricky. And then finally, we're going to talk about thyroid eye disease, which I don't know if everybody's as familiar with it, but there's some really exciting medical treatments for it that I think it's exciting to bring that to this area. So we're going to start with lid lesions. So spooky forest with the Halloween theme that we're doing. But when we see a patient with a lid lesion, it's important to consider the big picture. So does the patient have other lesions similar in other parts of their body? Does the patient have a history of skin cancer? Have they had exposure to a lot of UV in the past? So those are some things to keep in mind. We're going to go over some characteristics of malignancy to look at when you guys are seeing patients in clinic. We're going to talk about some specific lesions and things that may point towards those things. And then finally, we'll talk about how to stratify these lesions, which ones can be watched, which things have to be removed or biopsied right away. So by the end of this, you should be able to see a patient like this, bump on the eyelid, and decide, well, is this something that really needs to be addressed, or is this something that maybe bothers the patient and can come off for that reason, or maybe it can just be watched? So before we talk about specific lesions, we'll talk a little bit about characteristics of skin itself. I'm not going to bore you with too much detail about this, but just know that there are different layers in the skin, and each layer has different cell types that may be the source of different types of skin lesions. And there are different appendages associated with the skin. Our friend the teen wolf has many hair follicles. Other appendages in the skin include sweat glands, such as eccrine and apocrine glands, as well as oil glands, like sebaceous glands. So this is going to be kind of interactive. We're going to go through a couple of cases. Again, with the Halloween theme, I do have candy. So anyone who gets a right answer gets a piece of candy. I've got the choices of Reese's, Twix, and Snickers. And you get an extra piece of candy if you actually catch it, because I'm really bad at throwing things. So first case, we have a 65-year-old man who has a 6-month history of this lesion that you see in the lower lid. And he's only there because his wife made him come. It bleeds a little bit, it crusts, but otherwise it doesn't hurt, doesn't really bother him too much. Does anyone have any idea of what this might be? Yeah, in the front. I agree. What do you want? Snickers? Okay. Well, step one is opening the bag. Yes. I might have somebody else help me with the Snickers. Oh, scissors. Well, if somebody else passed out the candy. And here's the rest. Okay. So we'll talk a little bit about basal cell carcinoma. So it's actually the most common eyelid malignancy, and like many other skin cancers, it's related to UV damage. Specifically with basal cells, it's related to the basal cell of the epidermis being affected. And again, similar to all skin cancers, affects mostly in fair-skinned patients. With these particular ones, they're most common in the lower lid and the medial canthus. And you can see in the image that some of the hallmarks, you can appreciate that it's got this kind of raised pearly border, and you can see these fine blood vessels over it, that telangiectatic look. And so the next question, what location is associated with the highest risk of recurrence and mortality for basal cells? Any ideas? This one's a little bit tricky. Yeah, you got it. Medial canthus. So we got a right answer right here. So That is correct. Basal cell carcinomas that arise in the medial canthal area and the vertical midface, that you can see that this diagram of that H zone, which is the high risk zone for any kind of skin cancer, those tend to be highest risk of recurrence and mortality. So the next picture, if you are squeamish at all, shield your eyes. So here are a couple of patients who, while basal cells tend to be pretty slow growing, don't really tend to cause that much issue, if they're neglected for a long time, they can turn into something like this, where they can be pretty disfiguring and devastating. So that's why it's important to get them diagnosed and get them treated. So, next question. Which of the following is not a characteristic of an eyelid malignancy? So we've got ulceration, firmness, pain, matarosis, or pearly borders. You're right, pain. Our little ghost friend agrees with you. So, characteristics of malignancy include ulceration, which we saw also with that basal cell that we looked at earlier, induration, so swelling, irregularity, destruction, which we can appreciate in this image. It's destroyed some of those tissues. They can be non-tender, and again, like the basal cells, telangiectatic, and with pearly borders. And so here's another lovely picture. 47-year-old male with HIV, unknown CD4 count, who has a 1-month history of this thing, which was biopsied, and he was told it was benign, but it came back. What do you think? Four? Good guess, because of HIV, but no, not quite. So, any other guesses before I tell you guys? So this is actually a squamous cell. We're going to talk a little bit more about squamous cell carcinoma, which it can look like a basal cell with a similar look, in that they can be nodular like a squamous cell is. And they can have the scaliness, which you can appreciate more in this image, which you've seen it in the previous slide. It has this kind of scaly appearance to it. Go back. So they can be ulcerated, and again, sun damage, fair-skinned individuals. That's a common theme with most of these skin cancers. Squamous cells, though, can be a lot more aggressive, so it is important to catch these pretty early, which, again, shield your eyes. If you don't like seeing gore, here are a couple squames, left alone, not treated. So, again, important to get them diagnosed and treated. And so here's another 82-year-old male, history of squamous cells, 1 month of this thing on his right upper lid, and it hurts. He was told to try warm compresses, which haven't done anything. What's the next thing that he needs? A referral. I agree. Yes. Agree. Does anyone want the candy, or should I just tell you? Yes. 4, yes, right over there. Excisional biopsy. So this is an interesting case. So this case is interesting because it demonstrates that you can have a lesion that probably early on it looked a lot like a chalazion. Just like, we're always afraid of sebaceous cell. That's what we're taught, that it can look like a chalazion. If it doesn't go away, get it biopsied, get it taken off. Which this actually isn't a sebaceous cell, which we'll talk about, but it just shows that these things can be tricky, and the clinician who told him to do warm compresses probably wasn't out of the realm of reasonable when he first presented. So this is actually a Merkel cell carcinoma, which is a really rare but very malignant tumor. Comes from a sensory cell called a Merkel cell. They can grow really fast and they can metastasize. So they're so aggressive that when they're taken off, they need a pretty wide margin of 5 millimeters. So if you think about that's half a centimeter, which doesn't seem like much, but you think about it, like you take off a papilloma, you're literally just taking off the bump. But if you're taking off like a 5 millimeter, you're taking off like a whole centimeter diameter, which on somebody's face can be pretty big. So, and these are pretty, the survival is not good, 25 to 35%. So some of these lid lesions can actually be pretty high mortality. So we take for granted that it's just a bump on somebody's eyelid, but they can be really important to diagnose. And so here we have a 75-year-old female with sleep apnea who has this lesion, and she's concerned because her sister had a skin cancer. based on the appearance, what do you guys think this one is? Yeah, I agree. Number 3. So in the back, again, candy number 2. So it's an Apocrine Hydrocystoma. So this is another one of those things that I see a lot in my clinic. So we'll talk a little bit more about those. So they're smooth cysts, which are near the lid margins, and very common, and they're actually an adenoma, meaning they come from a glandular tissue. So they can fluctuate in size, they can get pretty itchy, and if they're big enough, they can actually weigh down the lid if they're on the upper lid. So those are reasons that insurance may even pay for these things to come off if they're bothersome. They're affecting the vision by weighing down the lids and things like that. So it wouldn't hurt to leave them alone, but I do take these off a lot. And this one, so 68-year-old female, hyperlipidemia with all of these lesions that you see in the image, and they itch. She's also got lesions like this on her chest. What do you think the diagnosis for these? Number 3? Yeah? Close. Not quite. Yep. Who said 4 first? There were a lot of 4s. Candy for everyone. So, yeah, it's a seborrheic keratosis. So they have this, the textbook terminology for this is it's got that greasy stuck-on appearance. And, you know, when they're small, they're pretty well outlined, and they're relatively flat, even though, I mean, they're raised, but they've got kind of a flat top to them. But when they get bigger, they can be kind of verrucous, meaning they can get these horns to them, which are actually the keratin plugs that are on the surface of them. I mean, kind of like an apocrine, like a hydrocystoma, they can get itchy. Cosmetically, they're not great to look at. They're really easy to take off, so I have taken a lot of these off too. And, you know, if they look suspicious, it's easy enough, send them to pathology just to confirm the diagnosis. And so we're going to talk a little bit more about actinic damage, so UV damage. So like I said, for the basal cell, the squamous cell, the predisposing thing for these cancers is UV damage. And UV damage can cause all kinds of changes in the skin, like a loss of collagen and elastic fibers. You can get all of these signs of sun damage, including mottled pigmentation, epidermal atrophy, wrinkles, scaly lips. You can get this stiff skin, which, you know, cosmetically those are a problem, but it becomes a bigger problem when you get these precancerous lesions, like an actinic keratosis. So an actinic keratosis is essentially a precursor to a squamous cell carcinoma. It's got a 20% risk of progressing to that. And so you can see in these images, it's got that scaly look where it doesn't quite look right. And so these are lesions that should be biopsied, and they can potentially be treated with just topical medications or even photodynamic therapy. And so, in summary, of eyelid lesions, so we've already talked about some of the characteristics of malignancy, including loss of lashes, induration, destruction of tissues, and all of those things. And we've talked about a couple of common types, as well as some of the non-malignant types, and even the ones like an actinic keratosis, which kind of fall in the middle, that still need to be addressed pretty quickly. And, you know, when in doubt, if there's anything that seems a little bit odd that you're on the fence about, just send it over. I'm happy to biopsy and send anything out just to confirm a diagnosis. So we're going to transition to Droopy Lids. This is our friend from, if you're familiar with the Goonies, does anyone know his name? Yep, Sloth. I had to look it up, honestly. But yeah, he's got a pretty droopy lid. So we're going to have a couple of cases on those. So these get a little bit tricky. So this lady, so she has trouble driving at night because she doesn't have enough light getting into her vision. Her MRD1s are a 0.5 millimeter on the right, 1 in the left. So based on her image, which again can be tricky, what do you think she needs? You're right, brow lift. So you can see, so here's her before, and you can see her after right here, where she just had the brows done, and she's nice and open now. Which, it's tricky, particularly in some of these ladies, because it looks, when you look at her pre-photo, like her brows are in pretty good position, like it looks like they're at the orbital rim, which is where they're supposed to be. But with these ladies, you have to take into account that they're plucking their eyebrows, and they're causing an optical illusion that'll make you think they're in the right position. So really, like when they see me, I'm not looking at the brow hairs as much as I'm looking at the skin, because the brow skin is a little bit different than the rest of the eyelid skin. So that can trick you. And we'll talk a little bit about why that's important later. But brow ptosis, so, you know, with age, things tend to droop a little bit because of laxity of the collagen and that loss of integrity to keep the brow tissues, which are actually kind of heavy, to keep them in their place. You see it happen earlier in the temporal brow, the temporal third, because if you think about the anatomy, the frontalis muscle is what lifts up the brow, and it ends at that 2/3 point at the brow. So it's very common to see a lot of people walking around. It looks like their brows are in pretty good position centrally, but then they've got a temporal slope there because that frontalis muscle is not there to help lift up the brow. And here's that other patient we saw on the slide after his brow lift, and he's nice and open and happy. So here's another lady, history of thyroid eye disease, referred for a brow lift. So the eyelids feel heavy, she's tired, and she has trouble with her needle point. What do you think she needs? Well, I can tell you. So, unless somebody had a guess. 1? Yes. Third candy.
Candy over there. For the staff.
For the staff? Oh, he's so generous. He's giving candy to everyone. But here is her after she had her blepharoplasty. So, I mean, take into account she has thyroid eye disease, so she has inherently this retraction. But after having the blepharoplasty, she's nice and open, and you can appreciate that her brows are actually in the same position they were in the pre-op photo. So if we lifted her brows, she would have been left with a surprised look all the time. And so a blepharoplasty, typically done for dermatochalasis, which we're all familiar with what dermatochalasis is. It's that redundant skin, which this is very significant dermatochalasis. Again, due to weakened connective tissue, loss of elasticity, often occurs with what we call steatoblepharon, which is what we saw in that thyroid patient, where it didn't look as much like this, where there's just skin hanging down. It's really in that case, she had a lot of this orbital fat that was prolapsed forward and causing that weight to weigh down her lids. So it kind of goes hand in hand. You get extra skin and fat sometimes going together. And it's all treated with this, basically the same surgery with a blepharoplasty. And so now we get to the interesting case about why it matters what kind of surgery we do for these patients. So this lady presented with irritation, pain, and light sensitivity in her left eye. She had a surgery done by a community ophthalmologist. She doesn't know what it was, but the ophthalmologist has skipped town and lives in Florida now. So what do you think they did for her? This one's really hard. So actually, what she had done was close. So she actually had a bleph, an upper bleph, which her complaints are in the left eye. If you look at that left eye, the brow is lower, but the eyelid is wide open. So if you think about the bleph, we're removing skin. So what happened probably, they took off too much skin, it's pulling the brow down, and she doesn't have enough skin to close her eye either. So she's just they've just shortened that anterior lamella so much that she's going to have this problem for the rest of her life. So that's why it matters, which surgery we do for what patient. You can really cause lifelong problems for these patients. So we already talked about the blepharoplasty side of things if you do it in a patient who needs a brow lift. And here's a patient who had a brow lift when she needed a blepharoplasty, where you can see pre-op she had all this, droop. Post-op, her lids are still pretty low, and she still has this redundant skin. Now her brows are just high, and she looks crazy. So these are reasons why it's important to know what surgery to do for which patient, which, I mean, that's ultimately when they see me, that's my job to figure out what they need. But this is why it's important. So we're going to transition to our last topic, thyroid eye disease, which, before you get offended that I showed Igor as an example, this actor actually had thyroid eye disease, and very severe with double vision misalignment, but he got famous from it, which doesn't make thyroid eye a good thing, but it's just an interesting little piece of trivia. So we've got a case of thyroid eye. This is a 44-year-old female on methimazole, hyperthyroid, who has irritation, tearing, and pain with eye movement. So what do you want to know in her history when you first see her? All of the above. Yes, candy for everyone. So yeah, you want to know all these things. And so thyroid eye, it's something, it's not super common, but it's not as uncommon as you might think. Like 19 out of 100,000 people a year get it. I mean, obviously I see more of it than the average person with what I do, but that being said, it's still like more common than you would think. We see it a lot with Graves' disease. 20 to 50% of patients with Graves will have it, but it's important to know that you can get thyroid eye disease on any spectrum of thyroid condition. You can be hypothyroid, euthyroid, and still have it. So it's a little bit confusing to call it thyroid eye disease. People who do get thyroid eye at some point during their lifetime, whether it's before or after their diagnosis of thyroid. And so the symptoms from this inflammation in the ocular tissues and the enlargement of the soft tissues in the orbit, which we'll talk a little bit about pathophysiology in a minute, but it's important, especially in oculoplastics. For a long time, there really wasn't much to do with it besides maybe give them some steroids, and then eventually when things get so bad, do disfiguring surgeries, which is, it's really devastating for a lot of these patients. But the last thing that we'll touch on is the new medicine that I talked about, that I alluded to earlier, that's really kind of the miracle drug for this disease. So in terms of risk factors for thyroid eye, smoking elevates the risk of developing thyroid eye. And in patients who have thyroid eye disease who smoke, the best thing they can do for themselves is to stop, because it's really the only modifiable risk factor that they have any control over. So that's the first thing I talk to any patient about with thyroid eye. It is more common in women, but when men get it, it tends to be more severe. Radioactive iodine treatment can kind of increase the risk of new onset or worsening thyroid eye, and with each decade of increase in age, that elevates the risk of thyroid eye. So we're going to just go through like a very brief pathophys, and then we'll talk about teprotumumab, which is what I want to get to. So basically, thyroid eye, you get this overexpression of this insulin-like growth factor receptor, and that insulin-like growth factor receptor is stimulated by these abnormal antibodies that a thyroid patient is producing. And so what those receptors cause is this fibrosis and enlargement of all the ocular tissues within the fixed bony orbit. And you can imagine, within a fixed area, if things are just expanding, you're going to get all of this pressure, pain, restriction in eye movement, all of the bad things that you see with thyroid eye, including the proptosis. And so teprotumumab, or Tepezza, which you might have seen commercials on TV, and like they've been doing some pretty good marketing, but it's been really amazing. So essentially what it does is it blocks that receptor that I was talking about and prevents that antibody from binding to it and stimulating that process. And so knowing that, it makes sense that it halts the progression of thyroid eye, but what we've seen in a lot of patients is that it can actually reverse a lot of the effects, which we'll skip that and just go through some images. So here's a patient's CAT scan from before and after Tepezza treatment. Tepezza treatment, it's actually a series of infusions, which you get 8 infusions spread out by 3 weeks each. So it's over a couple of months that you get the full treatment course. So here's on the left, you see the image of the extraocular muscles prior to treatment, and then on the right, you see after treatment, where that inferior rectus in particular was huge before treatment, and it's really become more of a normal muscle by the end. And so we have some patient photos too, which I think these are more exciting. So pre-treatment, 4 weeks in, so that's halfway through, or 4 treatments in, and then we have at the end, where she doesn't even look like she has thyroid eye. And here we have another, 4 treatments in, and at the end. Again, very normal looking. And this is probably the most impressive case of thyroid eye that I've ever seen. I've actually helped take care of this lady, where she's interesting because the studies on Tepezza were actually done on patients who hadn't had any treatments for thyroid eye. No steroids, no surgeries, no nothing. And chronic thyroid eye for years. She's had decompressions, she's had eye muscle surgery, she's had everything. She's been on steroids. Nothing's helped. And even was approved for 4 treatments, and then finally at the end, which it's giving somebody their life back. So it truly is a life-changing drug. So I'm really excited to bring that to this area. I don't know if I've seen any patients who've been on it since I've been here, but I've seen how much it can improve these patients' lives. And so if you have any thyroid eye patients, send them over, because I'm happy to get this started here, because I think it really can make a big difference for these patients. So typically, the first infusion, it's a half dose for the first infusion, just as kind of like a safety check, and that's always done at an infusion center, which, you know, they're all over the place. And the company, Horizon, has been really proactive about helping to set that up for patients, just because insurance companies don't want to pay for this, so the company's been really proactive in getting this to people and get the insurance companies to pay for it. So the first is done at an infusion center, and in some cases, the rest of them are done at the infusion centers also, but in the place I was at before, what we were able to set up was home infusions, which is really nice for the patients, where the medicine will be delivered there, a nurse will come, do the infusion once every 3 weeks. They don't have to worry about anything. So I'm hoping to get something like that started here once we get, you know, a flow with how to get this all approved. So I am anticipating that this will be, this will work really well here. I mean, like any facility that I'm working at. So yeah, so this facility will have to figure out where the infusion centers are here, and get that set up. And then, you know, depending on the insurance, if they're able to approve for home infusions, we'd like to do that too. So we're still kind of getting the ball rolling on figuring out the best way of getting the step one is getting it approved by the insurance company, which is the biggest hurdle. They require a lot of documentation, which once we get that done, it'll be really easy to get the infusion set up. But, you know, if you have a patient, we can talk about it and try to get the ball rolling right away. Any other questions right now? Yes. So that's a good question. We don't know. So this medicine was approved, I think, January 2019, and there was a couple of months where production was halted because the facility that produces this medicine was used to produce COVID vaccine for a couple of months. So really, we have about a year of solid data. So it's hard to know if it's a forever effect, and I think there's still studies being done. Does everyone need 8 infusions, or do some people need 3? Do some people need 12? Do some people need 2 rounds of infusions? So we're still figuring that piece of it out. But this is the prelim data that we have right now. And the interesting thing is I've seen a lot of patients on this, like, you know, at least like 50 maybe. And I don't think I've ever seen a patient say, the side effects of this thing are so bad and the payoff is not enough that I need to get off of this medicine. Like, I think every single patient I've seen, even if it's not a complete regression of thyroid eye symptoms, every patient has seen some kind of positive effect, which I don't think I can say that for any medicine I've seen for anything. So it's really, like I said, it's really kind of a miracle drug. So with that, I think I'm pretty much out of time. So that's me. One of my Halloween costumes. There's my phone number, my email address. What was that? Oh, you're right. You know, funny story, I actually did wear this in clinic. And this was during my residency, and I worked at, like, I was on a rotation where I was in the urgent clinic, and I was seeing, like, really, like, patients out of shape. And I was seeing this one patient, he was blind, and he was with his family, and they said, by the way, your doctor is dressed as a giraffe today. And he got a big kick out of it. So yeah, there's my contact info. I'm at all these offices. I'm happy to talk to anybody about any patients that they want sent over. And I'm really happy to be here. Yes?
Do you have any rule of thumb as far as what you would consider removing as far as skin lesions are concerned? Dr. Wiley's rule of thumb when they come into my office is anything somebody doesn't have to take their clothes off to show them.
Oh, I mean, I guess it depends on what the lesion is, but typically I would say around here. I mean, I had a patient show me her armpit once, and I said that's not quite my area of expertise. But yeah, typically I'd say face. Yes. Any other questions? Okay. Well, thank you.
And specifically, I'm going to be speaking about the Hydrus microstent, giving an overview of the device, and also discussing some of the clinical outcomes that we have out to 5 years now, so pretty long-term data. So just to take a quick poll, how many of you have seen a patient with a Hydrus before? Is that something familiar here? Okay, so quite a number of you have seen the Hydrus, so let's just dive right in here. So as we all know, glaucoma is a progressive disease. About 4.5 million patients in the U.S. are diagnosed with glaucoma. Probably the vast majority of patients we see in our clinics have more of the mild to moderate severity, but certainly there are a smaller portion of patients who have more moderate and advanced disease. Now, minimally invasive glaucoma surgery, which we also often call MIGS, has been around for several years and has really increased our options in treating patients with glaucoma, particularly at the time of cataract surgery. So for most patients who end up being in the mild to moderate category, targeting the conventional outflow pathway, which is Schlemm's canal, has been pretty popular. And some devices which you may have heard of include iStent, iStent Inject, and the Hydrus, which will be the focus of my talk here tonight. On the other side, for more advanced cases, you could consider bypass devices that go straight into the suprachoroidal space or even the subconjunctival space. So as I mentioned, there's several MIGS devices available with different mechanisms of action to get the pressure down in patients with glaucoma. But I think central to all these mechanisms is that you really need a functioning Schlemm's canal for MIGS to work well, and so that you can get good outflow into collector channels. So this diagram, I think, kind of outlines the vast majority of the devices. So let's just start here on the left side, the red. So there are a couple of different devices that we call canal disruptive. Some of them include the KDB or Cahook dual blade, which is a goniotomy, and we sometimes do that in our practice here. And basically what the mechanism here is the trabecular meshwork is incised and removed to allow for better aqueous outflow into Schlemm's canal and then the collector channels. If you look on the orange, there's also a mechanism of action of actually dilating the Schlemm's canal to allow for better aqueous outflow there. And there are some devices that do that. The one that we particularly use in our practice is called the Omni. And it's actually a dual function. It dilates Schlemm's canal, and it also provides a goniotomy, so incision of the trabecular meshwork to allow for more outflow as well. Moving on in the diagram, if you look at the yellow, so kind of a canal neutral, so a trabecular meshwork bypass device. The iStent, iStent Inject are all trabecular meshwork bypasses where basically it's essentially a stent, and so there's an opening towards the anterior chamber, so aqueous flows through that device and out through the trabecular meshwork bypass directly into Schlemm's canal and then collector channels for appropriate drainage. And then lastly, we have the Hydrus microstent here in the green, which also is a trabecular meshwork bypass, but in addition, it's a little bit longer. So it stays within Schlemm's canal to kind of stent it open, and then it kind of takes a 90-degree span, so greater access to collector channels for greater outflow. And this just kind of diagrams, I've kind of briefly touched upon it, but it all started with the iStent, a single bypass device, and then they developed the iStent Inject, which is 2 devices, a couple clock hours away to increase the bypass and the coverage. And then the Hydrus microstent, again, as you can see, is a little bit longer and scaffolds the canal to get better access for collector channels. So the stent itself, it's about 8 millimeters in length, and it's made of a alloy called nitinol, so it's nickel and titanium. And it's very biocompatible. There have not been any reported incidents of any allergy reactions or any intolerances. And it's slightly curved to match the curvature of the Schlemm's canal. And as you can see here, there's 3 little windows that face the anterior chamber, the aqueous for outflow. And then there's also the canal-facing side where it then gains access to the collector channels. So the way the Hydrus works, it's considered to have a trimodal mechanism of action. So we've talked about how it's a trabecular meshwork bypass. So this is a gonioscopy picture here, if any of you have seen the hydrus actually. Usually we're sitting temporally, so you may see it in the nasal angle. And so here you can see on the proximal end of the device, we call it the inlet, and that's actually open and exposed to the anterior chamber, and that's how aqueous enters the device, and then through Schlemm's canal, and then accesses the collector channels. We talked about how it serves as a scaffold. I think this pathology slide kind of demonstrates this really well, where the hydrus literally is dilating the Schlemm's canal to keep it open for better outflow. And then just based on the span of the device, it's able to access more collector channels just because it's longer. So this is a video here of the hydrus being implanted at the time of cataract surgery. So again, small incision, and you see the hydrus just kind of glide right into Schlemm's canal, and you can confirm the appropriate placement by looking at the 3 windows and making sure that it's in an appropriate position, and then also confirming that the proximal end of the device, the inlet, is sitting right where you want it to as well. And again, if you're looking for this on gonioscopy on the post-operative examination, you'll likely find it in the nasal quadrant. All right, so that's a brief overview of the device itself. Does anyone have any questions so far before we kind of go into, does this actually work? So I think that so there's a Horizon clinical trial. It's a pivotal trial in looking at hydrus outcomes. It was initially a 2-year trial, but they have actually follow-up data up to 5 years. So I figured I'd just go right into that, just so you can see for yourselves, does this work and is it sustainable? So in terms of the study design, it included patients with mild to moderate primary open-angle glaucoma, which is what hydrus is indicated for. Of course, they had to have a cataract. They had to be on at least 1 medication. They could not have had any prior glaucoma surgery, but an SLT was acceptable. And what the patients who were involved in this study, what happened was they underwent a 4-week period of what they called a washout. So they stopped all glaucoma medications and established a baseline medication-free intraocular pressure. Then they underwent cataract surgery and were randomized 2-to-1 to either getting the hydrus stent at the time of cataract surgery or just cataract surgery alone. And then periodic visits through that initial 2-year follow-up, checking pressure, how many medications they're on, and safety measures and things of that nature. And then they took that one step further and continued following up to the 5-year time point thus far, with a fairly good retention rate of 80% from that initial cohort. And so I'll show kind of the long-term findings that we have to date so far. So if you look at this graph, basically what it's showing over time, so up to the 5-year time point, you have in blue the hydrus group, and then you have in the gray color just the cataract alone group. And at the 5-month time point, 66%, or about 2/3 of patients, were medication-free still at 5 years with the hydrus microstent, compared to a little less than 50% in just the cataract surgery alone group. So there's a statistically significant difference with the hydrus group in terms of being medication-free 5 years out. And you can see just over time as well, there is a difference anywhere from 20 to 30% between the 2 groups. So overall, it shows kind of prolonged efficacy of the hydrus stent. Now, if we look a little bit more carefully into, let's say, the 1 medication patient, because probably most of our patients are just on 1 medication, the vast majority. And the pie graph here on the left does show that about 50% of patients, about half of our patients, are on 1 medication who are on prescribed glaucoma prescriptions. And so in the Horizon cohort, kind of similarly mirrored what real-life statistics are to that respect. So if we look at the patients who are on just 1 medication preoperatively, where did they stand at 5 years? Well, in the hydrus group, just about 3 out of 4 patients remain medication-free at the 5-year time point, compared to about 50% in the cataract surgery group. So again, showing a sustainable effect of being able to remain medication-free. And I think what this basically highlights is that cataract surgery with hydrous is a unique opportunity to provide these patients with mild to moderate glaucoma on one or more medications the possibility to have long-term medication independence. And in terms of, now this is all kind of clinical data. In terms of our practice data, I would also say that along these lines, more than half of patients who get the hydrous stent, we're often able to get them off of one medication or even more. So because of this, and I'll show a little bit more data, we've really had a lot of confidence with the hydrous stent, and you probably will often see patients who are on drugs. We'll have that conversation with them when we're seeing them at the cataract consultation, and these results kind of give us that confidence. Now, what about the patients who are on more than one medication preoperatively? Well, as you might expect, the rates of being medication-free at 5 years kind of drops as you're on more preoperative medications, but it's still pretty good. So at 5 years in the hydrous group, about 2/3 of patients who were on 2 preoperative medications remain medication-free at 5 years. And then about half of patients who are on 3 or 4 medications remained medication-free as well. So again, you have the ability to give patients the option of doing MIGS, and you can get pretty good results in terms of keeping patients medication-free. So again, it's just kind of striking data in terms of efficacy of MIGS devices like the hydrous. And in terms of intraocular pressure, this basically just shows that over the 5-year follow-up period, the hydrous group maintained a pretty steady reduction in intraocular pressure of at least 8 points relative to baseline, and remains, a statistically significant reduction relative to the cataract surgery group. And I think this is actually probably one of the most important findings of this study, in that eyes treated with the hydrous were 2.8 times less likely to have additional invasive incisional glaucoma surgery after 5 years. So that includes a trabeculectomy, tube shunt, or some other form of cilioablative procedure. And so that, I think, if you can prevent patients from having to progress to more invasive procedures, I think that is certainly something that we want to offer our patients. And then just kind of an interesting observation from this analysis in this study is that more than half of the patients who required a reoperation, again, incisional invasive glaucoma surgery, only had mild severity at baseline at the beginning of the study. And so I think this just really highlights that, number one, glaucoma is a progressive disease, and it can be unpredictable in terms of its progression. And just kind of highlights the importance that we need to be treating these glaucoma patients early and effectively to try and reduce, the need for additional surgery. So just kind of wrapping up here, in terms of safety, out to year 5, in terms of intraocular pressure elevation, loss of vision, visual field loss, corneal edema, and persistent inflammation, the hydrous group and the cataract surgery group are pretty comparable. The only main difference was there was peripheral anterior synechia, or PAS, noted around the hydrous microstent in a small percentage of patients. But clinically, that didn't really have a big effect because the intraocular pressure in those patients were very similar to the patients without PS. So it didn't seem to have, although it was noted, it was not clinically significant. Now, endothelial cell count loss. As we know, with doing cataract surgery, phacoemulsification, there's going to be some endothelial cell loss to be expected. When you add the hydrous, you get about a 2.5% extra reduction at the time of surgery. But as you look over time, as this graph shows, it kind of stabilizes. There's not, when you get past that immediate, post-operative period, there are no sustained significant differences between the hydrous and the cataract surgery group. In fact, over time, it's pretty much within the normal limits of what you would expect over time. As you get older, the endothelial cell count to decline. And why is this important? Well, I did talk very briefly in the very beginning. There is a way to bypass, there's a bypass device for the suprachoroidal space. It's called the CyPass, but You may or may not have heard it because it was recalled in 2018 because, as you see here on the far right graph, there were actually long-term issues with endothelial cell count loss, which you don't see here with Hydrus. And so they removed it from the market because of that concern. But thankfully, we don't see that with the Hydrus. So this is just kind of summarizing here, based on all the data that we have available, the American Academy of Ophthalmology, in their kind of glaucoma preferred practice panel, has acknowledged that Hydrus is a very effective device. And as a result, from this, some of the clinical outcomes that I've described here, and just our own findings when we're seeing our patients, we've had a lot of confidence with the Hydrus and other MIGS devices, and it really is a great option to discuss with patients at the time of cataract surgery when they have glaucoma and when they may be on one or more medications. And this is kind of just summarizing what we've discussed about. So any questions about that? Have any of you, seen a patient through the post-operative period with Hydrus, and have you been able to get patients off medications, or has the pressure been stable? I'm just curious if any of you were to comment on your experience, or any questions about how to manage a patient, how to get them off the drops. Yes?
Is the Hydrus visible with just slit lamp?
Sometimes it can be. For example, in pretty myopic patients with deep anterior chamber, I can sometimes see the nozzle, that like proximal inlet, just on looking anteriorly. But most of the time it's just visible on gonioscopy. And you can confirm, basically when you look, again, you should be kind of looking in the nasal quadrant for the device. You should see the 3 little windows within the trabecular meshwork, and then you'll see kind of sticking out into the anterior chamber, but shouldn't be rubbing on the cornea, and typically should not be on the iris, but kind of just in between that proximal inlet, which is where the aqueous enters the device.
That's the gun.
Correct.
I have a patient that you guys do one shot.
Mm-hmm.
It's at nasal, but the other one's at 7 o'clock.
Depending on the positioning, it could be just a little bit like a clock hour off nasal, supranasal, or infranasal, depending on the eye.
So he would not have put one in the 7 o'clock
In which eye? Do you remember?
right eye.
The right eye.
It's 3 o'clock, right at 7.
The right eye, it should be more at the 3 to 4 to 5 o'clock position. And then opposite for the left eye, typically. Now, there are other devices that we may do, like eye stent. Infrequently we sometimes do that. Yeah.
If I might chime in,
Yeah.
The different surgeons have different sort of techniques. When I put them in, I tend to, like if I'm doing the left eye, I'm sitting at like the 3 o'clock, and I'll sort of reach across and I sort of put it off to the left there. So mine won't end up right at 9 o'clock. Mine would be sort of more towards 8 or 7 o'clock.
Only on you.
Oh, so if I'm sitting here, it's going to end up down here a little bit. If I'm sitting here, it's going to end up here a little bit. So basically across from our wound and a little bit to the left. That's how I place them a little bit.
So every surgeon's a little different, but in general, the nasal-ish, plus or minus a few clock hours.
Nasal and both eyes.
Could be a little infro or supro. Yeah.
It's very visible with the slit lamp. Is it possible that they can move or come around, come out, reposition?
That is extremely rare. I have not encountered that. They're pretty much over time, it starts to scar in there as well, so it really should not be mobile.
This is IOPs today with 10 in each eye.
Well, that's good.
It's fantastic. His target pressure is 18. It's phenomenal. He's extremely happy. Just how visible it was with no gonioscopy.
Yeah, they sometimes can be. And you can confirm, though, if you're ever concerned, just put a gonioscopy lens there, and as long as it looks right in trabecular meshwork, you can see the 3 windows and a little bit of poking out of the inlet, it's in an appropriate position.
I think that's normal to see just the tip of the nozzle without gonia. Yeah, the nozzle. I think the nozzle sticks out farther than the other devices that we use. So I think it's actually kind of easy to see them without gonia. So don't think it's too unusual.
Yes.
So the
So I think it's highly dependent on the patient, and everyone has their own way of doing things. Personally, what I would do, so if a patient, I look at the severity of glaucoma. If the patient has mild glaucoma and they're on one medication, and say, you know, we want them in the teens, mid to high teens, let's say, and I'm seeing them 1 day, 1 week, and they're like, let's say mid to high teens or right where we want them to be, then I would trial off the drop and then see them back at 1 month. And if they're still in that target range doing well, I would continue them off the drop. Now, it's a little bit different. Say, you know, through the 1 month post-operative period, pressure is still not quite where we want it. I'd keep that drop on, and then at some point you could try taking the drop off and seeing how that pressure responds. If it's not, you know, if it's still higher than you'd like, you could put that drop back on. Similarly, if a patient has a little bit more severe, like moderate glaucoma, say they're on 2 medications, well, you could peel one off and see how they do, and kind of do it in a tiered approach that way. But honestly, if they're doing pretty good, like say pressure 10 or something like that, at the one day or 1 week point, I think that's a great opportunity to peel back a drop and then see how they do over that couple of weeks. And if they're doing well, I think that's a good indication that you could keep it off.
I had him on Lecanafloss and Rosolomide.
Mm-hmm.
So for the cataract surgery, I took him off the Lecanafloss, put him on the Rosolomide in both eyes.
Mm-hmm.
Then was with the Rosolomide.
Sure.
But Lecanafloss is gone. And maybe wait about a month and try to take the Rosolomide.
Yeah, you could even do like one eye, right? Because the hydrous in both eyes, and see how they do. And if you see a noticeable difference in one eye, then that could be telling that. If the hydrous eye remains at 10 or something like that, the other eye, you know, is higher. You know, that would give you more indication that it's working. All right. All right. Thank you.
Chuck Roseman here. And I'm just going to wrap up by talking about a service that we offer at this location and over at Brecksville, same-day cataract surgery. And we had started implementing it prior to March of 2020, but I think it's really picked up quite a bit as people want to limit their visits to different offices and things like that. And so basically, the same-day cataract surgery, you guys have diagnosed the cataracts, you've determined they need the surgery, and we get them over here and end up doing the procedure on the same day, which has several advantages for the patient and for you and for us. So preoperatively, I wanted to put up a picture of Dr. Augustine. It doesn't really have anything to do with this, but I mean, the ball's really in your court. You have to take a lot more ownership of these patients, which I think is a good thing and what we all would like to do, because we're really relying on you to make sure that this is a good candidate for the procedure. And so identifying any other causes of decreased vision, because as you all know, if it wasn't identified before the surgery, then the surgery caused their retinal vein occlusion or their keratoconus. Treat the ocular surface pretty aggressively, even if they're maybe not terribly symptomatic. Aggressive treatment will lead to better measurements for our lens selection. Patient education on, just the basics. There are different lens options, and then we've got packets that, we can get for all of your offices to give to the patient as they leave. And then the way it works is, when the patient is set up with the same-day surgery procedure, your front desk will email us, our same-day surgery team, and we'll reach out to them and really get the ball rolling as far as all that's concerned. I think the biggest advantages are that you, who know the patient and know their family and have been treating them for the past decade, are in control of this situation. We may look at someone on paper and say, man, that's a good candidate for a toric multifocal lens. you may look at the same patient and say, the last time I tried to fit him in contact lenses, it took 8 pairs of trial contacts and they're still not happy with it. Or this guy's hobbies include working on, circuit boards. And in those situations, you know that that patient's not good for this sort of thing. Let's keep it simple and, keep rolling, as the best we can. Patient retention is also big. I've worked at other systems where the patient's referred in for surgery and we can take the patient and then we do their pre-ops and then we do their post-ops and then we prescribe their glasses and they're like, well, why should I go back? You guys are doing all of this for me. With this situation, they come in for surgery and they're back in your chair as early as day 1. You kind of manage how much of the post-operative care you want to take on. And then collaboration and respect between OD and MD. I feel like in this practice, out of all the places I've worked, the optometrists have, very big say in how we're proceeding with surgery, what are the right options for this patient, in managing them. I think our surgeons like to be involved in that, but primarily they like to do surgery. And so I put up a picture to exemplify this. That's Dr. Karpuk, who runs our same-day surgery over in Brecksville, and that's Dr. G before she had refractive surgery, and they're sharing an ice cream. And that's just nice, and it shows the collaboration between our optometrists and ophthalmologists. So after the patient leaves your office and is referred to us for same-day surgery, our team will reach out to them. They'll have a telehealth visit with me, and I'll have your records, and we'll kind of reiterate what you've already discussed with the patient, talk about different lens options and what to expect day of the surgery. From there, we communicate with the same-day surgery team. Our billing reaches out to them, and they work with anesthesiology to make sure everything's set up for the day of surgery to go as smoothly as possible. When they come in, it's our surgical workup. We do biometry, we do topography, we do OCTs, we dilate the patient. There's always the stipulation on the phone that if something is uncovered during the same-day procedure, well, their surgery may have to be delayed. I'd say that's very uncommon, just based on the referrals that we get are pretty much spot on, and anything that needs further attention prior to surgery has often been taken care of. Being a large volume practice is nice because we don't have to order in a lens for every patient. We have a big stock of lenses, and so pretty much all the options are available to us. If someone comes in and they want a toric multifocal and they need a MIGS procedure on the same day, they can get that done. We've got the lenses on the shelf, and we can get them taken care of with that. Another nice aspect is the compounded drop that we use. We don't go completely dropless. I think it'd be possible to do it because we do inject some medication, a steroid and antibiotic at the time of surgery. But we've discussed, and it's kind of nice to have the compounded drop that we have that's once a day. If you're doing a dropless surgery and there's a lot of inflammation day 1, and you say, okay, we need to put you on a drop, the perception is something's gone wrong with my surgery. Whereas if we say, well, you're on 1 drop, why don't we bump it up to 3 times a day for the first week? I mean, you kind of maintain the status quo, and it's still less than the 8 to 12 drops a day that a lot of people are getting without the compounded drop. Post-operative care, again, it's in your court. If you say, I don't want anything to do with the post-operative care, send them back when they need glasses, that's fine. If you say I want to see them at 1 week, also fine. If you want to take over the whole thing, we have a lot of docs that do that. And so really it's whatever you'd like to do or whatever you're comfortable with. Just know that we're always available should anything come up. Going through the call center is an option. You've got our emails. We can give you our cell phone numbers. As long as it's not during a Buckeyes game, feel free to call. But really, the benefits are for the patient. There's less visits, more expedited process. The benefits are for you. You're in control. You don't risk, losing patients or things like that. And the benefits are for the community in general. There are more cataract surgeries that need to be done, and there are not more ophthalmologists that are doing them. So as ODs work at the top of their level, that allows the surgeons to stay in the surgery center and keep the whole system going as we would prefer it to be. And so if you have any questions about the same-day surgeries, you could ask now, or Nanette's the expert as far as more logistical things, as far as that's concerned. And we've got the surgeons here and everything. So if you have any questions, go for it. Yeah.
As far as with the same day, when I see that patient and I'm debating, are there other things in play? Is there potential for another go? Where do you want us to come down and say, instead of same day, let's schedule you in for an appointment with you or the surgeon here before, so that if I'm thinking no go, I can avoid it for you guys.
When in doubt, don't. I guess there's a lot of situations. We used to, when we started this, say only the most basic of situations. No pathology whatsoever. We can't do it. Let's keep it basic. Now, as long as the patient has their expectations and knows about other, ocular or ophthalmic disease that may be going on, and it's not active. They've got active macular edema. Okay, probably not. If they're, have an active PVD, probably not. But I would say most people are candidates for the same-day surgery. Is there anyone in particular you would say, oh, absolutely not?
I think if you have a patient who is pretty particular, maybe type A, it might be better for them to not do the same day approach, so you can have more shared time to explain all the options and make sure
Mm-hmm.
I was just trying to think about how your schedule is thrown off on the no-go stuff. It's going to be hard, I guess, when you get too many no-goes, this is going to throw you off.
And also, what disrupts the schedule is if there's a surprise discussion that takes a lot of time too. So any patient that you know is going to be a lot of discussion time, probably maybe a separate appointment. If you're thinking that they might need MIGS, another thing that cues us up really nicely is send all your testing so that we can look at all the data and say, okay, what's the best MIGS plan for this? Do we need to just do like ECP alone, or do they need the deluxe? ECP plus the Omni plus the Hydros, whatever. So the more information that we have, the better. But if you think it's going to be a long discussion with a lot of complex stuff, probably a separate visit would be better. Just even not just for our logistics, for the patient too, because that's a lot of information overload for them. They're just like saying, okay, okay, I guess I'm going to the surgery. We want them to be confident when they're making their decisions, so that afterwards, they can say, okay, yes, that was really great care that I got. Or say that there's a complication, that they're not like, oh, this happened bad because, I was rushed and blah, blah. We don't want to put ourselves in that position, or you.
So you're okay with a more conservative approach?
Yeah, no, definitely. Yeah, that's fine. No, you will not be faulted for sending even like, okay, I just thought it might be, but it might be complex. That's okay. You won't be faulted. You won't fault you for anything. You're our friend.
Yeah. So we do wavefront aberrometry, topography, and tomography on all these patients. And as we said, we've got the whole gamut of lenses back there, and so it's not really been a big hang-up for us. And we get a good feel from that, first of all, from the referring doctor. Secondly, from the time I take on the phone with them. Something about being the patients being at home and not sitting in the exam chair feeling like they're interrogated, I feel like we get a lot of good information on their, a lot more truthful information on their personality and their preferences and things like that. And so, you know, your records and our phone calls help to alleviate a lot of that. But the first priority is the patient comfort. And if it's just not feeling like it's something they're confident in going through, we certainly have no problems delaying anything.
And another thing about that, post-LASIK patients, of course, we'll catch this on the prelim call or the teleconference call, is like getting the old LASIK records is helpful because we have special calculators that we do for post-myopic LASIK patients or post-hyperopic LASIK. So if we actually can get the time to and put the effort to get those old records, that enhances our ability to get just the right lens too. So information, having it all at our fingertips, take some time to gather it. And if you guys can help us gather it, or at least give us a little time to do it, again, with the pre-telehealth visit, that's helpful too.
So I was getting a little pushback on how long the whole procedure was taking, especially for individuals. Are you still making people wait out in the car? That was a big deal. People were really pushing me on that about it. They had to wait out in the car as they were waiting for evaluation, etc. So are people now allowed back in the office and all that? That's all back to normal?
Yeah. Yeah.
I know the waiting rooms get well used nowadays.
Okay,
Yeah.
okay.
Jeff, at what point do they meet the surgeon?
After we've done the dilated fundus exam, gone through all the testing, I'll walk over to the surgery center. We'll lay everything out on the table, talk about the patient and what the tentative game plan is. Then the surgeon comes over and we all powwow together and, you know, have the final game plan and go over everything from there.
So are you the lead for same day here
Mm-hmm.
in this facility, and then
Carpuck.
Carpuck is the rest?
Uh-huh. On the day of the surgery, it's about half the day, so 3 to 4 hours that they're generally here. But compared to multiple visits, I think most patients are happy with it. But we usually tell them 4 hours, and that's an overestimate. So. Anyone ready for the second half of the CE meeting?